Hello, I'm John Stoffel. I'm a urologist at the University of Michigan. I'd like to talk with you today a little bit about urinary diversion for neurogenic bladder. This is a subject that's near and dear to my heart. I care for a lot of neurogenic patients in my practice, and I really do think it is a good solution for challenging problems. This talk, I think, is going to be also, though, about why certain patients need cystectomy or why they can benefit from it. I think that's almost equally important for this population, in addition to Hello, I'm John Stoffel. I'm a urologist at the University of Michigan. I'd like to talk with you today a little bit about urinary diversion for neurogenic bladder. This is a subject that's near and dear to my heart. I care for a lot of neurogenic patients in my practice, and I really do think it is a good solution for challenging problems. This talk, I think, is going to be also, though, about why certain patients need cystectomy or why they can benefit from it. I think that's almost equally important for this population, in addition to just learning about the technical details of it. I'd like to thank also the organizers of the conference here, particularly Toto. It's been a pleasure working with you, and thank you for inviting me to participate in this. I come from the University of Michigan. This is in the center of the United States. You can see Ann Arbor is listed here. Just as an aside, I'll tell everybody it's been between 0 and 20 degrees Fahrenheit here, and so I am ready for spring to start, ready for things to warm up. So let's talk a little bit about some drivers as to what are the decision-making factors that affect why certain neurogenic patients ultimately end up at cystectomy. I think you can break these things down into two main categories of safety and quality of life. And so for safety, we're talking about things like upper tract protection. What can keep them out of renal failure and prevent hydronephrosis? Soft tissue infections, urinary tract infections, skin erosion or skin damage from ulcers, and autonomic dysreflexia. For quality of life, I think this is really a subjective measurement, whereas safety is much more maybe an objective measurement. The quality of life determinant really is a discussion with how satisfied patients are with their bladder management. This involves how much time they spend caring for their bladder, whether or not they're changing activities or decision making based on caring for their bladder. It has a lot to do with the resources they need to be able to function with this. These two things, both safety and quality of life, I think really contribute to the overall health and happiness for the patient. Cystectomy, I think, is a clear failure of either safety or quality of life, and is a very dramatic and hopefully very effective step to help regain kind of even footing in either one of these or maybe both of these buckets. Now, neurogenic bladder, I think, is really a misnomer. It's almost like saying oncology is cancer. Neurogenic bladder is filled with lots of different pathologies, and it depends on where the nervous system has been affected. It's very difficult somewhat to compare the conditions. For example, Parkinson's is a progressive disease that affects the brain. Spinal cord injury is a sudden traumatic injury that affects the spinal cord. This is different from multiple sclerosis, which is a progressive injury that affects the spinal cord mostly. And this is different than spina bifida, which is a congenital condition. All these have affected the nervous system in different ways and at different time points, and therefore I think they ultimately have different expectations of how the disease condition is going to be managed and what the expectations are. Now, with this in mind, I think that for a neurogenic bladder patient needing care, I think there's certain barriers they need to get through in order to kind of reach good safety and quality of life. And these barriers are things that I think the treating physician has to really strongly consider, particularly when moving towards something like cystectomy. I think one of the first things is the natural history of the disease. The life expectancy is something to take very strongly into condition. So patients with a rapidly progressing neurologic condition, cystectomy may not ultimately be the best option for them. Whereas a spinal cord injury patient with a fixed injury and a likely longer stable expectation of long-term health, this may be something that could be a better long-term solution for them. So knowing the natural history of the neurologic condition affecting them is an important thing to first consider. This also really informs the testing strategies too. I think how often you want to be able to screen patients and how we want to be able to evaluate them will really determine what their safety is and then also what your quality of life measures are. I think if a condition is changing quickly, you want to be able to measure the quality of life much more frequently as compared to much more stable condition. And finally, all these things contribute to how do you calculate a surgical risk versus benefit. And I think this is one of the key components that really needs to be examined carefully before progressing to a very significant surgery for patients with a benign condition. Really need to look to make sure that the outcomes and the benefits are outweighing those risks. So we're going to talk briefly here today about some of the drivers that cause people to progress towards urinary diversion. And these are, again, keying in on safety and quality of life. I want to talk a little bit about outcomes from diversions and then I'll spend a little bit of time, a small amount of time on some technical considerations like what to do with the bladder. Do you need to leave it in or take it out? What to do with the bowel? Who benefits from a colostomy at the same time? So let's start with a safety condition that I think many times drives ultimate decision making. This is detrusor sphincter dyssynergia. It's most commonly seen in the neurologic conditions of spinal cord injury, multiple sclerosis, and spina bifida. In spinal cord injury, it can be strongly associated with changes in voiding pressure, particularly, again, patients with a lesion above T6. And there's evidence that suggests that patients with autonomic dysreflexia may be at more risk for urinary tract infections, low compliance, which we'll talk about in a second, and maybe overall morbidity. It is a condition that we really do kind of flag as a warning sign for patients and a potential safety issue. Patients with uncontrolled autonomic dysreflexia in spinal cord injury sometimes progress to cystectomy just because other methods do not help control this relatively dangerous condition for them. On the other hand, multiple sclerosis, it's very unclear whether or not DSD actually carries a large amount of morbidity. In a very nice French review for disease in 2007, they present evidence that they feel like it does present upper tract risk. Whereas a lot of the US data from UT Southwestern and ours from Michigan, we really don't see a strong association with it all, particularly as evidenced by hydronephrosis or progressive morbidity. Spina bifida, likely there is a relationship though between DSD and renal deterioration. This has been shown by some of the larger series, by David Bloom and Stuart Bauer. Nice review here in 1998, also showing some association with it. So DSD, I think, is a potential safety issue for some specific neurologic conditions. This is just a scatter plot of a study that we did at Michigan showing patients with urethral closure pressure above 20 centimeters of water really had a higher probability of showing DSD on some other studies like EMG and VCUG. And so we can try and measure it as a continuous variable, but most of the time DSD is really looked at as whether you have it or not based on EMG or VCUG. Second safety issue that I want to talk about is bladder compliance. Bladder compliance is a calculation. It's a change in volume over change in pressure. You can see here on the left there is a pressure volume curve, and this is a normal filling curve. You can see as the volume fills up, normally the pressure stays pretty flat in the phase 2, as you can see here. Normal compliance is generally greater than 15 centimeters of, 15 milliliters per centimeter of water. People say 40 is also is usually what most normal patients will show. So low compliance, however, the red line, you can see that there's very high changes in pressures for low changes in volume. This is a relatively dangerous condition because pressure can build up very quickly in the bladder. So a low compliance is a low number. It's less than 15 milliliters per centimeter of water. And again, you can see that normal compliance comparatively is a zero or low change in pressure for increasing volume. And so what can cause low compliance in a neurogenic bladder? Well, one thing can be a contraction against a fixed bladder outlet, and that's why DSD can potentially be dangerous in some conditions. Urinary tract infection also can be associated with loss of bladder compliance. And we think what it has to do with is a change of the extracellular matrix or increased collagen depositions and loss of elastin. Some thought that chronic Foley catheters in the setting of TruSure overactivity can also cause inflammation and loss of compliance. This is a film of a patient that we treated that is a clear classic radiologic evidence of low compliance. You can see that pressure has to go somewhere. This patient had DSD, bladder filled up, and ultimately pressure was reflected up into the upper tracts. This patient required a transplant. So there's some good data to show that low compliance impacts upper tract risk. This study is a meta-analysis of 49 studies. I think it was very nicely done by Musco, published in 2018. And just very briefly, that the odds ratio were almost 8 times, meaning that patients with low compliance had odds ratio of 7.88 of having upper tract changes in kind of a combination meta-analysis. Using a little bit more liberal definition of McGuire's to TruSure leak point pressure of greater than 40 centimeters of water. Now, odds ratio is also very high, showing that patients with high leak point pressures also have upper tract changes. So I think the data is very good showing this. I think the relationship, however, between indwelling catheters and low compliance is not quite as clear. A lot of what we think about risk from catheters in neurogenic patients comes from Weld study in 2000. It was a very large, very nicely done study of 316 patients, and they really noted that patients with intermittent catheterization had a higher risk, had a significantly higher incidence of normal compliance than patients using a Foley catheter or a suprapubic tube. This really has kind of shaped a lot of our perceptions of the risk of indwelling catheters in neurogenic patients, specifically spinal cord injury patients. I think it's more challenging to be able to extrapolate that. We all have patients like I'm showing you here. This is a patient who was a spinal cord injury patient who had a suprapubic tube for greater than 20.
Hello, my name is Jeremy Myers. I'm from the University of Utah, and Toto asked me to talk about patient and surgeon shared decision-making in urinary diversion. I'm really honored to give this. categories: conduit urinary diversion, continent catheterizable pouch or right colon pouch, and Jeremy Myers. I'm from University of Utah, and Toto asked me to talk about patient and surgeon shared decision making in urinary diversion. I'm really honored to give this talk. This is a real passion of mine, and I've been so impressed with the movement in reconstructive urology within the Philippines. So the types of options I'll be talking about today are three main categories: conduit urinary
Korea. It has been the tertiary hospital that has been leading medical advancement of South Korea for the past 130 years. It is linked to the Medical College of Seoul National University, and it has a main building, pediatric hospital, cancer center, several clinical trial centers, and branch hospitals. The urology department was established in 1946, and more than 150 board-certified urologists have been produced.
We're the oldest baby company.
Deck safe system, simple and quick to administer.
all over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products. This is our raison d'etre. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
It's a long and complex journey to generate the innovation that may lead to a new medicine. Across Astellas worldwide, teams of experts from research, development, pharmaceutical technology, sales representatives, and medical affairs are working together to achieve our goal of changing tomorrow for patients. Drug discovery research is the starting point of creating a potential new medicine. Drug discovery research begins with understanding how the body functions and the mechanisms of disease. We can then target ways to treat or prevent worsening of symptoms. Our scientists then identify the most effective treatment methods and narrow down the drug candidates. The drug candidates are evaluated through preclinical research adhering to strict pharmaceutical standards to optimize programs for clinical trials. The drug candidates generated through drug discovery research are tested by rigorous clinical trials to evaluate the appropriate dosage, efficacy, and safety in human use. Astellas has established a global development organization to conduct clinical trials that meet compliance regulations in each country. Once evaluated efficacy and safety, a new drug application to obtain marketing approval is submitted for review by regulatory agencies in each country. Consistently delivering high-quality and reliable medicines to patients is the key role of pharmaceutical technology. At Astellas, we conduct research to explore the most innovative production methods and formulation design to enable commercialization of our products. Pharmaceutical technology manages as a team the entire supply chain process, from sourcing the raw materials to manufacturing products and managing the logistics of delivering final products, to ensure the quality of our medicines meet global standards. Sales representatives contribute to the treatment of patients by promoting appropriate use of medicines to help healthcare professionals deliver optimal care. The key role of sales representatives is to deliver approved information and also receive feedback about the efficacy and safety of medicines to help healthcare providers make appropriate prescribing decisions. Medical affairs plays a critical role in enhancing the medical and scientific value of the products developed and delivered by Astellas. We work to understand how the external environment views the value of Astellas' medicines and translate those insights into strategies and activities that fulfill our stakeholders' current and future information needs to ensure the safe and appropriate use of our therapies. Medical affairs creates scientifically supported, valuable data for Astellas products through research studies or clinical trials. From research and development to pharmaceutical technology to sales representatives and medical affairs, multiple teams throughout Astellas work collaboratively across geographies and functions so that patients can receive innovative, high-quality and reliable medicines and therapies. We all work together to deliver innovative medical solutions for patients worldwide.
We stand on the forefront of healthcare change
and turn innovative science
into value for patients.
We stand on the forefront of healthcare change and turn innovative science into value for patients.
Astellas, changing tomorrow.
When you're the oldest baby company in the world, you learn something important. Babies grow up. They fall down. They have fevers. They break bones. Some develop acne, allergies, and nearsightedness. They need to be stitched up, given a chance against HIV, protected from the sun. They have ups and downs and babies of their own. Sometimes they go to dark places and need help getting back. That's why Johnson & Johnson isn't just a baby company. We're a company developing robotics to find and treat cancer. We make custom joint replacements, restore heart rhythms, repair shattered bones, help you back from strokes, and make every chapter of your life the best it can be. No, Johnson & Johnson isn't just a baby company. We're a keep you healthy your whole life company. And from the day you're born, we never stop taking care of you.
The Zoladex Safe System, simple and quick to administer. Put the patient in a comfortable position with the upper part of the body slightly raised. A prosthetic belly will be used for this demonstration. Step 1. Clean the area below and lateral to the navel with an alcohol swab. Step 2. Remove the syringe from the pouch and hold it at a slight angle to make sure part of the implant is visible. Remove the plastic cap and needle cover. Hold the Zoladex injection by the top of the protective sheath, like a dart with the bevel facing up. It is not advisable to position your thumb on the plunger, as you may depress the plunger prematurely during insertion. Step 3. Pinch the patient's skin at the stomach below and lateral to the navel. Hold the needle with a bevel facing up at an injection angle of 30 to 45 degrees. Step 4. Insert the needle with a bevel facing up until the protective sleeve touches the patient's skin. Step 5. Depress the plunger until you hear a click. Step 6. Withdraw the needle and allow the protective sleeve to slide and cover the needle. Dispose in an approved sharps container. Step 7. Apply pressure on the injection site and gently place a sterile dressing to cover the site. Let's take a look at the whole process in one single motion. The Zoladex Safe System, simple and quick to administer.
All over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products, This is our raison d'etre. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
It's a long and complex journey to generate the innovation that may lead to a new medicine. Across Astellas worldwide, teams of experts from research, development, pharmaceutical technology, sales representatives, and medical affairs are working together to achieve our goal of changing tomorrow for patients. Drug discovery research is the starting point of creating a potential new medicine. Drug discovery research begins with understanding how the body functions and the mechanisms of disease. We can then target ways to treat or prevent worsening of symptoms. Our scientists then identify the most effective treatment methods and narrow down the drug candidates. The drug candidates are evaluated through preclinical research adhering to strict pharmaceutical standards to optimize programs for clinical trials. The drug candidates generated through drug discovery research are tested by rigorous clinical trials to evaluate the appropriate dosage, efficacy, and safety in human use. Astellas has established a global development organization to conduct clinical trials that meet compliance regulations in each country. Once evaluated efficacy and safety, a new drug application to obtain marketing approval is submitted for review by regulatory agencies in each country. Consistently delivering high-quality and reliable medicines to patients is the key role of pharmaceutical technology. At Astellas, we conduct research to explore the most innovative production methods and formulation design to enable commercialization of our products. Pharmaceutical technology manages as a team the entire supply chain process, from sourcing the raw materials to manufacturing products and managing the logistics of delivering final products, to ensure the quality of our medicines meet global standards. Sales representatives contribute to the treatment of patients by promoting appropriate use of medicines to help healthcare professionals deliver optimal care. The key role of sales representatives is to deliver approved information and also receive feedback about the efficacy and safety of medicines to help healthcare providers make appropriate prescribing decisions. Medical affairs plays a critical role in enhancing the medical and scientific value of the products developed and delivered by Astellas. We work to understand how the external environment views the value of Astellas' medicines and translate those insights into strategies and activities that fulfill our stakeholders' current and future information needs to ensure the safe and appropriate use of our therapies. Medical Affairs creates scientifically supported, valuable data for Astellas products through research studies or clinical trials. From research and development to pharmaceutical technology to sales representatives and medical affairs, multiple teams throughout Astellas work collaboratively across geographies and functions so that patients can receive innovative, high-quality and reliable medicines and therapies. We all work together to deliver innovative medical solutions for patients worldwide.
We stand on the forefront of healthcare change
and turn innovative science
into value for patients.
We stand on the forefront of healthcare change and turn innovative science into value for patients.
Astellas, changing tomorrow.
When you're the oldest baby company in the world, you learn something important. Babies grow up. They fall down. They have fevers.
Good afternoon, everyone. We will be starting program. Please stand by. We will be starting in 2 minutes. Good afternoon, everyone. Welcome to the 2021 of Santa Tomas section of Urology postgraduate course. Our program was first conceived towards the tail end of 2020 when our then newly appointed section chief, Dr. Carlo Bisnar, assigned to me to take on the task of preparing for this year's postgraduate course. A lot of ideas were thrown in the ring, but we finally decided to go with reconstructive urology as a theme. This field of urology has been slowly growing in popularity in the past few years, as evidenced by well-attended courses in various PUA events. This time around, we decided to ride this wave of popularity, but decided to change things up by tackling another aspect of urologic reconstruction. Urinary diversion has long been in the armamentarium of a general urologist, but its basic concepts have been muddled through the years. In this postgraduate course, we sought the help of 4 of the most respected lecturers from the Society of Genitourinary Reconstructive Surgeons to review us on the topic so that we may apply these principles in today's clinical practice. The second day of the postgraduate course is a unique concept wherein we teach the audience how to deal with complicated cases in the backdrop of a relaxed game show type atmosphere. Again, we were fortunate enough to secure the assistance of 11 rising stars in the field of recon uro. We will be talking about our morbidities and unusual cases without the tense atmosphere usually associated with these kinds of events. But before everything, we would like to thank our sponsors for helping us in this endeavor. And we would like to kick off our program with a very important lecture coming from a very good friend from Korea, Professor Sung Yong Cho. But before that, let us all start by placing our hands on our chest for the national anthem of the Philippines.
Sa lahat ng mundo, sa simula at sa lahat
let us all now have our opening prayer.
A pleasant afternoon, everyone. Let us put ourselves in the presence of the Lord, in the name of the Father, and Son, and the Holy Spirit. Amen. Dear God, thank you for this afternoon. Thank you for the opportunity you have given us to discuss this scientific meeting. And as we all learn from this, may you help guide us to use this knowledge for the betterment of our patients. In Jesus' name we pray. In the name of the Father, and Son, and the Holy Spirit. Amen.
Thank you, Dr. Malyari. Now, before we start our event, we would like to introduce to you our beloved hospital director. Can you please place her picture on the screen, Dr. Ginto? Dr. Charito Malong Consolacion graduated from the UST Faculty of Medicine and Surgery in 2000 and finished her residency training in internal medicine in 2004. She did her fellowship in adult nephrology and she finished it in 2006. Currently, she serves as the hospital director of the University of Santo Tomas Hospital. Ladies and gentlemen, let us listen first to Dr. Malong Consolacion.
It gives me great pleasure to welcome all of you in this postgraduate conference organized by the Section of Urology in cooperation with the Department of Surgery. It is gratifying to note that despite the limitations brought about by this pandemic, we are still able to plan and promote activities such as this that will provide opportunities for us to share expertise among general to reconstructive urologists from the different centers and institutions. As a nephrologist myself, urologic problem is close to my heart, and I had worked with several urologists in order to reverse, maintain, and delay the progression of urologic diseases. Thank you very much for this chance, and let us work together to strengthen the learning and training of our younger colleagues. Good night, stay safe, and thank you again.
Thank you, Dr. Malong Consolacion. Now, I will introduce you now to our moderator for this session. He is Dr. Fidel Manalaysay. Can you please put his picture on the screen? Dr. Fidel Manalaysay is a graduate of the UST Faculty of Medicine and Surgery, batch 2009. He underwent his residency training in urology at the East Avenue Medical Center in 2017. He then proceeded to Yonsei University, Korea, to have his fellowship training in female urology and neurourology under Professor Kim in 2019. Currently, he is an active staff member of the UST Hospital and also our expert in neurourology and female urology. Ladies and gentlemen, our moderator for this session, Dr. Fidel Manalaysay.
Hello, good afternoon. Can you flash the picture of Professor? Yes. Our first speaker is Dr. Sung-Yong Cho. He finished his medical education in Seoul National University in Korea. He specializes in diagnosing and treating patients with urolithiasis, BPH, strictures, and upper tract urothelial carcinoma. He is the current director of the Specialized Endoluminal Endourology Stone Center and Usability Test Center in SNUH and an active associate professor in the Department of Urology in the same institution. He has successfully fulfilled many educational works, including online webinars, like a while ago, the ETS, Endoluminal and Technology Symposium, and has facilitated several workshops, like the OSTEG, or the Asian Urological Surgery Training Education group, in which many of us participated. Also, he performed several live surgeries in different urology meetings and has produced over 150 scientific papers. We are very fortunate to have him as speaker, as he will talk about overactive bladder. Without further ado, I will give the floor to Professor Cho.
Good evening, ladies and gentlemen. I'm Sung-Yong Cho, Hospital in South Korea. This is my great honor to be invited to this event. And today's topic is about the management of overactive bladder symptoms in patients with or without neurogenic bladder. I'm working for the Seoul National University Hospital located in Seoul, Korea. It has been the tertiary hospital that has been leading medical advancement of South Korea for the past 130 years. It is linked to the Medical College of Seoul National University, and it has a main building, pediatric hospital, cancer center, several clinical trial centers, and branch hospitals. The urology department was established in 1946, and more than 150 board-certified urologists have been produced. I'm running the Stone and Endourology Center for the first time in Korea since 2017, and the main focus is based on the flexible ureteroscopic surgery and endoscopic enucleation of prostate from surgical perspectives. Today, actually, I want to beg your pardon because I couldn't prepare some cases for management of overactive bladder diseases with an unexpected event this week in my hospital with my patients. So instead, I try to focus on the review of the management of overactive bladder diseases from general perspectives, and for the patients with neurogenic bladders in terms of mirror background medication. The first question can be about the effectiveness of mirror background for overactive bladder patients. As you can see the slide, a systemic literature search is showing that mirror background 50 milligram was as efficacious as antimuscarinics in reducing the frequency of micturition, incontinence, and urgent urinary incontinence episodes, with the exception of solifenacin 10 milligram. That was more efficacious than mirror background 50 milligram in improving micturition frequency and frequency of urinary urgency incontinence. Mirror background 50 milligram had an incidence of dry mouth similar to placebo, as you can see the right figure, and significantly lower than all included antimuscarinics. This study is to compare adherence and persistence across 6 chronic medication classes. And this retrospective analysis of pharmacy claims in a database of more than 64 million members enrolled in 100 health plans assessed persistence and adherence to drug therapy in these 6 conditions, and a total of 167,000 patients were identified. So 6 and 9 month persistent rates were 28% and 18% in the overactive bladder medications respectively. So adherence to overactive bladder medications was lower than to cardiovascular or anti-diabetic and oral osteoporosis therapies. This study is about the persistence and adherence with mirror background versus antimuscarinic agents. Actually, some, as you can see, the name of the antimuscarinics here in this table. And this study was performed in a setting of retrospective observational study in UK clinical practice. So this study included more than 21,000 patients, and in the unmatched analysis, persistence and adherence was statistically significantly greater with mirror background than with tolterodine ER and other antimuscarinics prescribed for overactive bladder in UK. Now, how about the evidence-based management of overactive bladder medications with regarding the mirabegron prescription? So evidence shows some studies about the use of mirabegron versus antimuscarinics, such as PREFER, PADOMI, and FAVOR studies. And post-marketing study can be the answer if you want to check the long-term use of mirabegron. You can memorize this figure to understand all the studies easily. The first study is PREFER study. And this was a 2-period, 8-week crossover, double-blind, phase 4 study in treatment-naive adults with overactive bladder for 3 months or longer, randomized to one of the 4 treatment sequences in 5511, as you can see this figure. So basically, this between this change of the medication, they separated with a 2-week washout period. So as you can see this graph, higher score indicates better perceived overactive bladder medications tolerability. So tolerability of mirabegron was significantly higher than that of tolterodine ER. Basically, both treatments were well tolerated to our patients. However, anticholinergic side effects were higher with tolterodine. So what about the other antimuscarinics, such as imidafenacin, fesoterodine, terodine, and sulfenacin? Patients were initially treated with antimuscarinics or mirabegron for 8 weeks in this study. When patients were refractory or intolerant to an initial treatment, drugs were switched to the other. A total of 117 patients were enrolled. And as an initial treatment, 60 patients were given antimuscarinics and 57 patients received mirabegron. Similar initial treatment efficacy was observed within these 2 groups in the whole patients. However, mirabegron was more efficacious to men with overactive bladder and responsive to a prior alpha-1 blocker. Dry mouth and constipation were less burdensome in patients treated with mirabegron. So this study concluded that mirabegron seems to have priority as an initial therapy with a distinct efficacy tolerability balance. So how about the change of medication from antimuscarinics to mirabegron? And how about the long-term use of mirabegron for more than 3 years? So now I'll briefly review the FAVOR study and PMS study. As you can see, the FAVOR study performed in Korea. This was a 12-week open-label study of adults with overactive bladder who had been treated with antimuscarinics within 2 years of screening and expressed dissatisfaction over poor efficacy or adverse events of antimuscarinics. All enrolled patients have received mirabegron 50 mg once a day for 12 weeks. So, as you can see this graph, the significant improvements from baseline to weeks 4 and 12 were observed in the frequency, urgency due to urinary incontinence, and urgency episodes per 24 hours. At 12 weeks, 80.2% 8% of patients were willing to continue mirabegron. So almost all patients, I mean around 80%, patients were satisfied with the prescription of mirabegron. But I think, in my humble opinion, patients normally follow their doctor's opinions, right? So there can be a little bias here. How about the long-term use of mirabegrons? Our Japanese friends performed a post-marketing surveillance study about the use of mirabegron for 3 years, and patients who had started mirabegron for the treatment of urinary urgency, daytime frequency, and urgency urinary incontinence symptoms associated with overactive bladder were followed for 3 years. So 1,138 patients were included in this study. The investigators considered mirabegron to be an effective treatment for about 77.8% patients. Significant decrease in overactive bladder symptom score, OAB-SS, were reported throughout the whole period. So treatment persistent rates after 1, 2, and 3 years of mirabegron treatment were 65.8%, 82.9%, and 46.7% respectively. Quite good, because almost half of the patients would continue the medication of mirabegron. So let's check the characteristics of Parkinson's disease for patients with the neurogenic bladder from the perspectives of mirabegron prescription, because Parkinson's disease or Parkinsonism is one of the most common diseases with neurogenic bladders urologists can meet in their outpatient clinics. Basically, the pigmentation of substantia nigra pars compacta dopaminergic neurons is due to the presence of neuromelanin, an irregular macromolecular pigment belonging to the family of melanins. But depletion of this neuromelanin in Parkinson's disease is typically indicated by loss of brown color. And yeah, in this area, as you can see the right bottom figure. Namely, the pigmented neurons of the substantia nigra are typically lost in Parkinson's disease. The classic features of Parkinson's disease are TRAP symptoms, namely tremor, rigidity, akinesia, and postural instability. And sometimes we can see flax posture and loss of facial expressions. Parkinsonism refers to any condition that involves the types of movement problems seen in Parkinson's disease. It can occur sporadically or genetically, as you can see this. Secondary Parkinsonism is when symptoms similar to Parkinson's disease are caused by certain medicines, a different nervous system disorder, or another illness. The importance is that if we correct some conditions in the secondary Parkinsonism, the symptoms can be relieved. So we need to find the secondary cause of this Parkinsonism as far as we can. So sometimes we can see, many times we can see the name of Parkinson plus syndrome. Actually, this is a group of neurodegenerative diseases featuring the classic features of Parkinson's disease with additional features that distinguish them from simple idiopathic Parkinson's disease. This is very important from the perspectives of BPH surgery. So yeah, many urologists are still considering the treatment option of BPH transurethral surgery for patients with idiopathic Parkinson's disease, right? It means more than a movement disorder, and loss of bladder control and sexual dysfunction can be main urological problems in atypical Parkinsonism. So, atypical Parkinsonism refer to a handful of conditions that share some aspects of Parkinson's disease, but have additional symptoms. They may progress faster and benefit less from medication. Much of the research into Parkinson's disease can be leveraged to understand and treat this atypical Parkinsonism. So now, based on this concept, we are familiar with the terminology of Parkinson plus syndrome. We have to be familiar with this Parkinson plus syndrome. I don't want to differentiate these four categories of atypical Parkinsonism today, because this is a role of neurologists, not urologists, right? But we need to keep in mind that multiple system atrophy, the second largest part of the Parkinsonism. Anyway, this causes movement symptoms and affects the network of nerves, namely the autonomic nervous system that controls blood pressure, digestion, and other involuntary processes. So while no current therapy can slow or stop progression, treatment can ease symptoms of atypical Parkinsonism. Because symptoms overlap across these conditions, treatments overlaps too. Obtaining reliable longitudinal information about everyday functioning from individuals with Parkinson's disease in natural environments is critical for clinical care and research. If we see the symptoms related Parkinson's disease, I mean IPD, it may mean the onset was several years ago. The extraction of timely information that meets the needs of patients, clinicians, caregivers, and healthcare regulators may be important. It is related to a choice of appropriate therapy as well. If the patient is, for example, suspicious of having MSA, then we should avoid prostate surgery, and we can prescribe some medications with poor prognosis and poor treatment responses. So the patient should be informed of this future treatment plan with the poor treatment response. And as you can see, the latest period to urinary disturbances, MSA shows is only about 1 year. And we have to give information about the possibility of urinary disturbances to our patients if the patient is suspicious of having MSA or other types of the typical Parkinsonism. It is time matters, and we have to give this information to them. There's a good sign and important information for patients. We have to know that the presence of a wheelchair, that means wheelchair sign, which can be a red flag for atypical Parkinsonism and indicates significant early postural instability. Symptoms were partially responsive to high dose levodopa. It means a poor response to medication therapy and prostate surgery. So maybe if you can see, the urologist can see the wheelchair sign, we have to maintain the treatment with just only medication, not with the prostate surgery. So rapid progression, the possibility of rapid progression should be informed to our patients. Now I want to review the use of mirabegron in the patients with Parkinsonism. When I performed the analysis of urodynamic profiles of patients with Parkinson's disease and MSA between 2005 and 2012, a total of 581 patients were analyzed. The mean patient age was 69.2 years. Patients with MSA showed a statistically significantly decreased maximum flow rate and increased post-void residual urine volume compared to the patients with Parkinson's disease. Voiding failure occurred more frequently in patients with MSA than in those with Parkinson's disease, and the odds ratio was 1.9. Patients with MSA showed a higher prevalence of low compliance, decreased bladder contractility, and increased rate of voiding failure. So, detrusor overactivity and impaired contractility were very common in patients with Parkinsonism, and MSA showed more significant impairment of lower urinary tract function than other conditions. So, we published the data in the Journal of Parkinsonism-related Disorder in 2015. But with regard to the prescription of mirabegron, so what options can we have as urologists for caring our patients with Parkinsonism patients? So at that time, I couldn't see much evidence about this. The first study about the use of mirabegron for neurogenic bladder patients was just a retrospective study. And this retrospective study was conducted including patients with Parkinson's disease who received mirabegron 50 milligram once a day for overactive bladder symptoms between 2012 and 2017. 50 patients, the mean age was 74 years old, and 50 patients were included. And before being treated with mirabegron, 56% had failed prior anticholinergic therapy experience. So after 6 weeks of mirabegron 50 milligram, only 5 patients, in 11.4%, had a complete resolution of their overactive bladder symptoms, and 25 patients, 50% of patients reported an improvement. Only 2 adverse events were reported during mirabegron treatment, and only 4%. One dizziness case and another diaphoresis that disappeared after mirabegron discontinuation. The conclusion was that the mirabegron has an excellent safety profile and appears to be an effective treatment for overactive bladder symptoms in patients with Parkinson's disease. But I think that this result was quite different from my experience, but while I take care of the patients with Parkinson's disease. So, well, actually, I was confused at the treatment and prescription policy across some medications, including 5-AR, ARI, bethanical, beta-3 agonist, and Botox injection. The evidence level was quite low. And actually, the previous retrospective study also shows a very low level of evidence to show the feasibility of the mirabegron used for neurogenic bladder patients. And our team actually planned to perform a randomized control study for this. So, yeah, the research title was the mirabegron for treatment of overactive bladder symptoms in patients with Parkinson's disease, a double-blind, randomized, placebo-controlled study. So we named it a PADOMI study. Yeah, our manuscript was finally accepted in the last year. I will introduce some details of this manuscript. Inclusion criteria were Parkinsonism patients with overactive bladder symptoms for more than 4 weeks. The patients were not necessarily restricted to a bed or wheelchair. I mean, the wheelchair sign I already told you. So overactive bladder symptoms questionnaire scores greater than 2, and OABSS urgence question scores greater than 1. After a 2-week washout period, the patients were randomized into placebo and mirabegron groups at visit 2. Visit 3 was performed after 4 weeks of medication. Mirabegron was finally prescribed to the 2 groups for the rest of the study period at visit 4. The mean age was 68.1 years, 72 males and 64 females were included. And the key point is shown in this figure, and that means that the overactive bladder symptom scores were significantly different between these 2 groups at weeks 4 and 8. The OABSS scores became the same in the 2 groups at weeks 12 after all the patients were prescribed of mirabegron 50 milligram. I believe you are getting the sense of it. This is my article, and please put up with this that I'm showing off. Anyway, the adverse events occurred in 27 patients, to 23.1%, and I'm sorry. And the degree was mild in 26 cases, and moderate in 5, and severe in 2 cases. Only 13 cases, 39.4%, showed medication-related adverse events. Acute urinary retention occurred in a single case, and the treatment satisfaction questionnaire showed no significant differences between these 2 groups. So, therefore, in conclusion, we recognize that mirabegron was effective in treating overactive bladder symptoms in patients with Parkinsonism with acceptable adverse events. And how about the cognitive function of mirabegron for elderly patients? Although we don't have any evidence about this, especially for neurogenic bladder patients, we can review the data of this manuscript and name the effect of mirabegron on cognitive function in elderly patients with overactive bladder, published in BMC Geriatrics recently. The outpatient aged more than 65 years with wet overactive bladder were randomized 1-to-1 to mirabegron or placebo, stratified by age. So the 887 randomized patients were included, and there was no statistically significant change in adjusted mean cognitive function score from baseline to the end of treatment in the mirabegron group or the placebo group. So they concluded that treatment with mirabegron for 12 weeks did not contribute to drug-related cognitive side effects in patients aged more than 65 years. And the pattern of change in cognition over time in an older OAB trial population does not appear to differ from that of subjects receiving placebo. So today, my take-home messages are like this. Actually, mirabegron is the best seller in Korea for overactive bladder management. So the mirabegron 50 milligram had similar efficacy to most antimuscarinics and lower incidence of side effects. This is the main reason for the best seller of mirabegron in Korea. And patients prescribed mirabegron showed greater adherence than those prescribed traditional antimuscarinics. Mirabegron was effective in treating overactive bladder symptoms in patients with Parkinsonism with acceptable adverse events, and treatment with mirabegron for 12 weeks did not contribute to drug-related cognitive side effects in patients aged more than 65 years from perspectives of evidence. So thank you for your attention, and this is my great honor to be invited here. And feel free to say, ask questions, or give me some comments. Thank you so much. Good evening, ladies and gentlemen.
Thank you, Professor Cho, for that informative and elaborate lecture about OEB. Kamsahamnida, Professor. We have about 10 minutes for the open forum. Pao, can you change the slide? Open forum. Okay. So, Professor, I think we have one question in the. Oh, there's another one. The first question, I think you already have responded to that. It's about it's from Donna Marie D. So how quickly does the medication start showing its effects? And if OEB symptoms improve, do we still need to continue the medication? Professor? Please unmute.
Please unmute, Professor.
Yeah, thank you.
Yeah. Professor, about this question, I think you already responded to that.
Yes, now I'm ready, because I clicked the unmute button so many times, but I couldn't do anything. So yeah, basically I prefer mirror background, basically.
Okay.
Yeah, usually mirror background for all overactive bladder patients to antimuscarinics. But if there is any contraindication for using the mirror background, then just I can choose some antimuscarinics. But when I consider the combination therapy, and dose titration is much helpful with antimuscarinics, for example, so small dose of antimuscarinic we can add to the mirror background, then just I think the low dose antimuscarinic doesn't affect a heavy constipation or other kinds of side effects. Then I usually prescribe mirror background first, and then I can add a small low dose of antimuscarinic. So that would be my first preference.
Yeah. I think for my answer to this, usually I ask the patient to come for follow-up after 1 week, and then in 1 week time, usually they will give you these respond if there's a improvement in symptoms. So for the next question, if medication does not work, are there surgical options, Professor?
Yeah, sure. But surgical option can be considered only for patients with idiopathic Parkinson's disease. Because, for example, if the patients have atypical Parkinsonism, the prognosis not so good, actually. So. And as I show you the disease progression curve, if the disease progressed too much, then the result will not so successful, and patients will not be satisfied with the results. So I don't recommend surgical option to my patients. And patients normally are reluctant to general anesthesia, but if they decided to undergo general anesthesia, they expect very good result. So if the patients, if I have to say many things, then patients should be informed about the prognosis, but they don't normally accept the results. after prostate surgery. So normally I recommend the medication to them. And if the medication would not be satisfied with them, then just I can give some information to our patients. But for atypical Parkinsonism, surgery should be avoided, I think.
Yeah. We have another question here. When do you prefer, Professor, beta-3 agonist over antimuscarinic?
And without any contraindication, my first choice is mirabegron.
Okay. Yeah. I also do that. I mean, my first choice would be mirabegron. So another question here is, what's your experience when combining antimuscarinics and beta-3 agonists? In cases of
Yes.
Parkinsonism versus Parkinson-like problems, do you outright request for urodynamics?
Yes, I always try to check the urodynamic study for for patients with neurogenic blindness, and when I ask, basically, I think not urologists, neurologists have some responsibility to differentiate the subtype of Parkinsonism, but normally they ask to urologists about the presence of urologic problems because they normally write in the chart like rule out Parkinsonism, but atypical Parkinsonism less likely. Then what is the answer? Just I asked the neurologist. So do you think this patient has idiopathic Parkinson disease? Then I can consider surgical option as well with medication treatment. So, but they replied to us, okay, just the probability is high with Parkinson disease, but I cannot say there is no he doesn't have any atypical Parkinsonism at all. So that's the problem. So they want to get some information from us to differentiate, to diagnose the atypical Parkinsonism with urologic problems with early onset. So I try to gather much information from including urodynamic studies and some other imaging modalities. For example, there can be hydronephrotic kidneys, so upper tract deterioration. So I try to get some more information about that anyway, as far as I can.
Okay, Professor. I believe there's no other questions here in the chat box. Oh, there's another one. In patients on mirabegron, for more than 3 months, do you encounter motion defects, Professor?
Basically, no. I think 1 month it would be enough.
Yeah.
So if they have some side effects in 1 month, then just we need to change some medications. But normally, for 3 months, patients is okay. And if patients complain of any kind of side effects later than 3 months, then we need to ask some more about the medication, this recent medications, of our patients, because they can be diagnosed another diseases and they can start to take some other medications together. So we have to ask some questions to our patients.
Okay. Thank you, Professor, for that wonderful insights and for your very great lecture. So right now, I would like to express the gratitude to our dear sponsors, namely Astellas, Biomedis, Johnson & Johnson, and AstraZeneca. And I would like to turn the floor to Dr. Abalahon.
Thank you very much, Dr. Manalaysay. Thank you, Professor Sung Yung Chu, for a very, very wonderful lecture on OAB. And thank you to all. Now, let us proceed to the main event. So first, I will like to introduce to you our section chief, Dr. Carlo Bisnar. Pau, can you please put Dr. Bisnar's picture on the screen? Dr. Carlo Bisnar is a graduate of the UST Faculty of Medicine, batch 2000, and finished his urology residency training at the UST Hospital in 2007. He then proceeded to the Philippine Children's Medical Center for his fellowship in pediatric urology. He currently serves as both the chief of the UST Hospital Section of Urology and an officer of the Philippine Society of Genitourinary Reconstructive Surgeons. Let us all welcome our Chief of Section, Dr. Carlo Bisnar.
A pleasant day to everyone. In behalf of the UST Section of Urology, it is a pleasure to welcome all the participants to the first day of this two-day postgraduate course on reconstructive urology. Today's event is also a start-off point in a series of activities in celebration of the 75th anniversary of the University of Santo Tomas Hospital on March 7, 2021. We are also proud to announce that this conference is being conducted in collaboration with our mother society, the Philippine Urological Association, and its recently established umbrella society, the Philippine Society of Genitourinary Reconstructive Surgeons. Hats off also to the head of our scientific committee, Dr. Mark Joseph Abalahon, and to all our UST urology consultants and residents who devoted their time in setting up this postgraduate course and managed to invite our esteemed guests. It is also an honor to welcome all our eminent speakers and guests from all around the world who are respected leaders in reconstructive urology and journal authors of our topics for today. Despite the time difference, they have managed to share with us their knowledge, expertise, and vast experience. The theme for today's conference, The Art of Urinary Diversion, is quite interesting, as very few urologists would discuss about it in conferences, but it is indeed still a vital proficiency for us. For most urologists, urinary diversion is a last resort, used only as a final course of action when all else has failed. But for our patients, urinary diversion is a sign of hope for their bladder and kidneys and for them to live a life free from dialysis. May we have a fruitful discussion ahead of us and apply today's modules and lessons in our clinical practice. Thank you and have a great day.
Thank you very much, Dr. Bisnar. Now, before we start our first lecture, I would like to introduce to you our dear PUA President. Dr. Ernesto Gerial Jr. graduated from the UST Faculty of Medicine and Surgery in 1992 and finished his urology residency training at the National Kidney and Transplant Institute in 2001. He did his fellowship training in laparoscopic urology at the Westmead Training Hospital in Sydney, Australia in 2002. Ladies and gentlemen, the President of the Philippine Urological Association, Dr. Ernesto Gerial Jr.
Good evening, everyone. It was such a privilege to be tasked to give an inspirational message as an introduction to this two-day scientific forum. When I was initially invited to give this message, I asked myself why I was chosen to do this task, supposedly to inspire the participants and the audiences of this meeting. And so I asked myself, should I inspire them as an alumnus of the University of Santo Tomas, our alma mater? Or should I inspire them as a urologist with a special interest in my chosen field of specialization? Or should I inspire them as a president of the Philippine Urological Association? How to start this talk really became a challenge to me. Just to give you a little background on my journey before I became a urologist, I was in fact rejected twice in my application as a urology resident and was even almost rejected the third time. With my persistence, I was finally accepted. I went through my training as an ordinary or a regular urology resident. But I am proud to say that perhaps I fared better because I worked harder and aimed to be more than just the average resident. I was one of those with the most number of research papers during that time. And my only desperation, and this is a fact, was I cannot win and never really did over the research papers done by UST urology residents in all research contests that I participated. I was always second, if not the third. And during my third year residency, I heard my consultants coming from a convention abroad talking about laparoscopy. It was the prime of minimally invasive laparoscopic surgery back then, and I clearly heard them discussing among themselves that such procedure, no matter how popular it is, would never be applied in practice in Philippine urology and might not even see it started during their lifetime, especially when it applies to donor nephrectomy, a procedure that was one of the most commonly done in our hospital. It was then that I asked myself, if they can do it somewhere else, why can't we do it here? What is so special about the procedure and the foreign urologists that us local urologists tend to shy away from it? Why are we considering ourselves and have accepted the fact that we are inferior to our foreign counterparts? This incident became a challenge and a motivation for me to prove them wrong. One may be due to curiosity, but the most part is trying to prove to myself that I can do it. I did not waste my opportunity to look for a training when I had a chance to be sponsored for the first time to present my research paper during the UAA convention in Malaysia back in 2002. There was a masterclass session in laparoscopy, the one I was really looking for and hoping to attend. It cost 50 US dollars back then to attend that masterclass, but unfortunately, I don't have such an extra money to pay for it. But determined to join, I found a way to squeeze myself among the tall foreign attendees rushing to enter the hall when the door to the session was open, and by all means avoided the marshals guarding the door. And there, hallelujah, I met my mentor, Dr. Howard Lau of Westmead Hospital, Australia, who willingly accepted me as his trainee, and the rest was history. I went to a foreign land to train, not waiting or depending from any support, sponsorship, or grant, which I thought might not really come. If there is a lesson here that I could use to inspire our residents and young urologists, it was the determination to pursue one's dreams and to have the courage to take the path where nobody dares to pass. Yes, one might say it could lead to uncertainty, but it can also be the road to your success. When I was starting my initial years of laparoscopic surgery practice, one of the few people who believed in me was Dr. Dave Bolong, a visionary who supports talented young and promising urologists like me back then, even if I am not a product of UST training program. And I am sure everyone, especially the young ones who were under him, would agree with me. I also need to mention Dr. Jason Letran, who supported and trusted me in co-managing his private patients. As I continued to perfect my skills, the organization of the Philippine Urological Association took notice of me and made me a part of their numerous scientific activities. I started giving lectures, both locally and abroad, on behalf of the PUA, and acted as the scientific chairman for 5 PUA conventions, and finally became a member of the executive council and crawled my way up to be the current PUA president. It was truly fate that brought me here. Now I see young and promising urologists embracing the principle, the very principle that I had back then. The perfect example will be the organizers of this postgraduate course. Urinary diversions and GU reconstructions are one of the many fields that urologists tend to avoid due to the difficulty and many nightmares that goes with these surgeries. But I really do admire the young generation of urologists who are pursuing the paths less traveled, for they truly are the ones that prove that the ones thought to be impossible are actually achievable, and they are the ones who could provide hope to patients who thought that their conditions are hopeless. Please bear in mind that it is through these challenges that we grow mentally and spiritually as competent healthcare providers. It is through the pain and courage of confronting and resolving problems that we develop courage and wisdom. I wish that young urologist who takes the riskier path in order to prove that a Filipino urologist can be equal, if not greater than their foreign counterparts, would continue to pursue their goals and that their drive flourish. They are truly the future of our organization, the PUA. Lastly, collaborating with our foreign colleagues has made the practice of urology standardized regardless of what part of the world you came from. And if there's one good thing this pandemic has taught us, it was the ability to maximize technology to bring in the rest of the international urology community closer to one another, making the world smaller such that sharing of knowledge, cooperation, and collaboration would never have been easier until this time. To those who conceptualized and organized this exciting meeting, I congratulate and salute you. And the PUA is committed to continually support endeavors and scientific activities like this. Maraming salamat po sa inyong lahat.
Thank you very much, Mr. President, sir. That was very inspiring, sir. We hope that the young urologists listening now are going to follow in your footsteps. Thank you very much again, Dr. Jeriel, sir. Now, let's proceed now to the main event. So let me introduce to you our first speaker, Paulo. Dr. Ginto, can you please post his picture? Dr. Francisco Martins is from Lisbon, Portugal. He did his fellowship training in 1992 at the University of Southern California in Los Angeles under Dr. Donald Skinner and Stuart Boyd. He also did an observership in 1994 at Brigham and Women's Hospital, Harvard University in Boston. Currently, he is a professor at the University of Lisbon School of Medicine, and his areas of major clinical interest are genitourethral trauma and reconstruction. Currently, he serves as the president of the Society of Genitourinary Reconstructive Surgeons. Let us all welcome Mr. President Francisco Martins.
Hello, my name is Jeremy. I'm from University of Utah, and Toto asked me to talk.
Professor Martins, can you open your video so we can spotlight you? Okay, Paolo, can you please play Dr. Martins' video?
Hello, I'm Francisco Martins. It's a pleasure to participate in this webinar on urinary diversions with such a distinguished panel, namely John Stoffel, Sean Elliott, and Jeremy Myers. I have good memories and keep them from my first visit to the Philippines. This was a fantastic meeting with when social distancing was not required. Well, just a brief word on history. Ferdinand Magellan was the first European to reach the Philippines in the early 16th century. He was said to do the first circumnavigation of the globe. Unfortunately, he was killed in a skirmish in the Philippines, and he was replaced by Sebastian Delcano. I'm just going to give you a brief introduction and overview on urinary diversions. Bladder cancer is not rare. Mortality rate averages 2 per 1 million. Radical cystectomy remains gold standard for muscle infiltrative disease. Radical cystectomy necessitates urinary diversion for bladder function replacement, and urinary diversion with or without cystectomy is also used as a last resort for benign diseases. So urinary diversions have a long history. Simon in 1852 performed the first urethrosigmoidostomy. In 1898, Gassuni, an Austrian surgeon, created a rectal bladder. In the early 1950s, Bricker popularized ileal conduit. However, this had been originally described by Zaire in 1911. And in 1959, Kamei performed the first ileal neobladder. It was not until 1980s that orthotopic diversion began gaining popularity. So what are the goals of urinary diversion? Maximum local tumor control, minimal complications, and best possible quality of life. The ideal urinary diversion should have undisturbed body image, should allow natural urination, continence, and safe upper urinary tract. There are three main situations when urinary diversion is needed. In pelvic cancer surgery, in context of a neurogenic bladder dysfunction, and non-neurologic debilitating conditions. So the functional components of a lower urinary tract are non-refluxing. They should be low pressure reservoirs. They should have a good continent mechanism and a conduit to the surface. The deciding factors to choose the right bowel segments are related to cancer control, age, and general health of the patient, technical issues, metabolic consequences of the urinary diversion, quality of life, and importantly, motivation, both of the patient and surgeon. Motivation is the most important factor. So, which is better or worse? To have a constant bag on your side, to wear pads, or to catheterize 4 or 5 times a day through an abdominal stoma? Patients are faced with this dilemma. It should be kept in mind that urinary diversion is not a trivial process. Patients need to learn how to adapt to a totally new and different type of daily living, often with new expenses. When choosing the right urinary diversion, actually at the present time, many expert centers still recommend ileal conduits, which are usually associated with worse quality of life. Why, despite more than more than 20 years of experience, continent diversions, both neobladders and cutaneous, have not gained popularity worldwide. So how do doctors and patients decide to have one type of diversion or another? Donald Skinner used to say that any candidate to radical cystectomy is a potential candidate to orthotopic neobladder. When choosing the right urinary diversion, there are potential reasons for surgeons not to perform continent urinary diversion, specifically insufficient surgical training, belief that continent diversions are associated with increased postoperative complications, high costs, and low financial reimbursement for such complex operations, and other different values. Well, take-home messages. What type of diversion is best as a relative concept, and physicians must present these treatment options to the patient in the most balanced and honest way. Biases are inevitably a factor in the discussion, and patients come to doctors in search of advice and expect them to give them the best recommendation with their own best interest as our guide. So some patients are more adaptable than others. Our obligation is to be sure that patients are given all the different options prior to scheduling their surgery. Thank you. Thank you.
Will join me again later during the open forum, where we will be moderating the questions of the audience. Now, for our next speaker, I'd like to introduce to you Professor Jeremy Myers. Can you please post his picture, Dr. Ginto? He completed his fellowship in genitourinary trauma and reconstruction at the University of California, San Francisco. He is an associate professor at the University of Utah and serves as the co-director for the Center for Reconstructive and Men's Health in the same institution. He is also currently serving as the secretary for the Society of Genitourinary Reconstructive Surgeons. And I would like also to thank him very much for waking up the earliest at 2 a.m. in the morning in Utah. We truly appreciate your effort, Jeremy. So let us all play his video first.
Hello, my name is Jeremy Myers. I'm from the University of Utah, and Toto asked me to talk about patient and surgeon shared decision-making in urinary diversion. I'm really honored to give this talk. This is a real passion of mine, and I've been so impressed with the movement in reconstructive urology within the Philippines. So the types of options I'll be talking about today are three main categories: conduit urinary diversion, continent catheterizable pouch or right colon pouch, and neobladder. I'm in an area in the United States that is quite rural. It represents 10 to 20% of the geographic United States within our referral area, and this is how it compares to the Philippines with an overlay map. Our population is about 30 to 40 million people, and there is a predominance of farming and ranching. So when I talk to people about urinary diversion, I often make the analogy between an ileal conduit or conduit urinary diversion and a farm pickup truck. It's reliable, and it's the workhorse of urinary diversion for bladder cancer. The first thing that I'll review with patients is about what they can expect for perioperative complications and what the experience will be like undergoing urinary diversion and cystectomy. We did this paper with Sean and John looking at urinary diversion in patients after prostate cancer radiation complications and published it in 2017. And it's really one of the papers I use to talk to patients about what to expect with surgery. It was in 100 patients. It was retrospective over a 10-year period. The risk of death in these men was 5%, and this is routinely what I quote when I talk to patients about urinary diversion. In addition, 15% of patients required an additional surgery within 90 days. Often this was to treat issues such as bowel obstruction, hernia, dehiscence, and infection complications. Also, patients, it is entirely common that they get readmitted for problems like pyelonephritis or wound infection, and about a third or up to 40% of patients are readmitted. Even though we're very conservative about letting them go home, we really want to make sure they're tolerating oral pain meds, eating, and having adequate bowel function prior to discharge. We don't do any rapid discharge protocols in these patients. So what can you do to optimize patients before surgery? In cancer care, maybe patients need surgery relatively quickly. With neurogenic bladder patients or patients with radiation complications, often the patients can wait and can optimize their circumstances before undergoing urinary diversion. One thing is diabetes. There's very mixed literature on diabetes and whether this increases surgical complications, but most of that literature looks at values like 6.5 or greater than 6.5. We often see patients that have out of control diabetes that really need to be brought down to a reasonable level before they contemplate such a serious surgery. Frailty. If patients aren't able to complete their daily tasks, they may not be an ideal candidate for the surgery. Often I ask if before the pelvic problem, were they able to walk? Did they walk in from the car? Can they climb a flight of stairs? Those are routine and very simple ways of assessing whether a patient's strong enough for surgery. And then finally, we spend a lot of time thinking about nutrition. We check albumin, and if they have low albumin and we're supplementing them with high protein, then we'll check their pre-albumin to see whether they have adequate protein reserves to undergo the surgery. Of all the markers, albumin has stood the test of time as being the single most important lab for predicting outcome after major abdominal surgery, and that's true in urinary diversion and cystectomy. This is a very nice study from Memorial Sloan Kettering, which was retrospective, looking at 1,000 patients undergoing cystectomy for bladder cancer, and they looked at complications and death associated with a normal albumin greater than 4 and a subnormal albumin of less than 4. They found in an adjusted analysis that any grade of complications was associated with low albumin less than 4, along with women having comorbidities. And also, interestingly, they found that continent urinary diversion was associated with a higher risk of complications. This was one of few papers that have shown this association. For the most part, there's very little difference demonstrated between different types of urinary diversions and complications. The same was true of mortality. Mortality was approximately 66% higher in patients that had an albumin below 4. You can see that in this nice overlay of the spectrum of albumin. And you can see patients below 4, and particularly when they got down to 3.5 or lower, had a mortality that approached 10% versus 2 to 3% when patients had albumin that was normal. Another paper from USC looked at the same impact of albumin, but they looked at an overall long-term survival rather than just perioperative outcomes. And you can see that a low albumin at the time of cystectomy at 2 years predicted a much higher mortality, 50% mortality in patients with an albumin, in this case less than 3.5, which is profoundly low. I think in some of our patients we'd be thrilled if they could get an albumin up to 3.5 that are having complications, for instance, of radiotherapy. What are some of the specific risks that I think about as a surgeon and often will talk with patients about? One is how to create a stoma. This is a very important surgical consideration. It is very important to site the stoma correctly. Obviously, an ileal conduit will be on the right side, whereas a colon conduit can be brought over on the right or left side. Typically, an ileal conduit is 2 finger breadths below the umbilicus and about 4 centimeters off of the midline on the right. Sometimes there's enough laxity in the mesentery to bring it above the umbilicus, and it usually goes about 2 finger breadths or so above the umbilicus if it's in an upward location. Typically, a colon conduit goes in the upper abdomen at that site about 2 finger breadths above the umbilicus. Sometimes it's critical to see the patient lying flat and also sitting directly up on the edge of their bed. This can really give some insight into where their abdominal creases are and how much egress of the costal margin into the abdomen occurs. Another really critical aspect of creating a good stoma is understanding the vasculature of the terminal ileum and the right colon. This is a blown up depiction of that vasculature. And one aspect of this vasculature is this arcade or connection between branches of the ileocolic as well as the superior mesenteric artery here. Now, this creates a relatively parallel mesentery over about 10 to 15 centimeters of the terminal ileum as it comes right up to the cecum. Another aspect to creating a good conduit is understanding the vascular anatomy of the terminal ileum and the cecum. There's an arcade that connects between branches of the ileocolic artery and the superior mesenteric artery. This arcade is relatively parallel as it courses along the terminal ileum over the course of maybe 10 to 15 to 20 centimeters of the terminal ileum. Understanding this parallel architecture will allow you to gain a lot of freedom for an ileal conduit and maybe someone where there's a challenge in bringing this up to the abdominal wall. Likewise, it'll allow you to create a very parallel catheterizable channel for a right colon pouch. So if we're considering getting adequate length in order to bring up this distal aspect and make a stoma in an ileal conduit, we would cut this vascular arcade a little more distally towards the cecum. If we want to create a longer channel that can come up to the abdominal wall, then we would cut this more proximally and rely on the parallel arcade to give us length for this catheterizable channel. This is an illustration of the terminal ileum. The cecum is down here, and you can kind of see through here, not perfectly, this vascular arcade being pulled up into a rough U. So for a conduit, we would cut this very close to the cecum, and we would get all of this freedom kind of stretched out to get a good length to create a stoma. For the colon pouch, the opposite is true. We get as long as we can on this more proximal terminal ileum to create a long channel. This is taking it. We use a bipolar cautery, but you can use any method. And here's our arcade that's been cut through, and we usually extend this all the way down. Don't have any problems with vasculature here. There's very robust arteries that come up on either side, the ileocolic or branches of the superior mesenteric artery. So what are some challenges? This is the type of patient that can create a very difficult situation in doing a urinary diversion. I spend a lot of effort in evaluating the size of the abdominal wall. Over on the left, this is a patient that has a very thick abdominal wall just below the umbilicus where the stoma will be created. And I usually start to worry about whether it's going to be feasible even at 3 or 4 centimeters thickness between the rectus and the skin. This patient has a 7 centimeter thickness, and in this case, I'd be thinking about alternatives to an ileal conduit. On the right-hand side is a patient with the same abdominal girth, however, has a very large amount of visceral fat and a very thin abdominal wall of 2 centimeters. Not that this doesn't increase the complexity of the surgery due to the large amount of visceral fat, but at least an ileal conduit or any type of stoma you create is typically much easier. One way to handle these situations is a non-everted stoma. This is a recent concept to me, and this was published in 2020. And it looks at a single center retrospective experience from University of Michigan in 42 patients. The patients were obese with a mean BMI of 30. They had a good amount of follow-up for stoma complications of 17 months. They found that 83% of the stomas were protuberant and did not have complication. And of the 42 patients, 4 had stomal retraction from scarring, probably related somewhat at least to the lack of eversion, so about 10%. And this can really improve stomal outcomes for patients where everting the stoma will create a flush stoma or create a recessed stoma. This is what it looks like. Here you can see the stoma is slightly everted only. It's brought out from the abdominal wall, and here's the mesentery. And all of that kind of epithelializes and creates a nice stoma over time, which is depicted over here. I think in this circumstance it's interesting to see this picture because certainly this isn't a patient that needs a non-everted stoma. So I'm not sure what the outcomes are in patients that really desperately need to have this happen, but it's something to keep in mind about creating stomas. Another way to handle this, which is typically the way I've tackled this, is to create a colon conduit as an alternative to an ileal conduit. One nice aspect of a colon conduit is as this robust marginal artery, which allows freeing up a distal or proximal aspect of the colon to bring it through a very thick abdominal wall. Another advantage is it can be anastomosed to the pelvis of both kidneys. If there's a lot of visceral fat, then getting the left ureter over to the right can create a situation where there's inadequate length and you end up using ischemic ureter. Also, often there's intense fibrosis of the ureters if there's been stents in place or the patient has radiation injury and a lot of manipulation to the retroperitoneum. Another aspect of the colon conduit is that the upper abdomen usually has a much thinner abdominal wall than the lower abdomen. People tend to be pairs in their lower abdomen and have a thicker abdominal wall. You can also accomplish a no bowel anastomosis conduit diversion when patients have a pre-existing colostomy, and this obviates the danger of an anastomotic leak, which is of critical importance in patients with severely radiated bowel, very poor nutrition, and who are debilitated. And so often this increases the safety of the operation and decreases mortality even from the surgery. This is what it looks like, a transverse colon conduit. Often the conduit is depicted as being intra-abdominal or within the bowl of the large bowel mesentery, but I find that it often works better to put this between the anastomosis and the stomach. So still intra-abdominal, but kind of arching over the duodenum and on the lower edge of the stomach to either side of the abdomen. The problem with a colon conduit is it's a whole different level of surgery. Often an ileal conduit we can do from a lower midline, or it can be accomplished robotically. With a colon conduit, we pretty much have to do a full laparotomy because we need to release the splenic flexure and the hepatic flexure and then deal with the upper anatomy of the abdomen and the pelvises of the kidney. Here's a depiction of the colon switch. So this patient had a colostomy. Now the colostomy is converted to a colon conduit, urinary conduit, and a new colostomy is matured on the right side. And this accomplishes a no bowel anastomosis surgery. One aspect of doing a colon conduit or a colon pouch is that patients need a bowel prep. There was some literature about a decade ago about not doing bowel preps in colon surgery, specifically colon resection. And this has been looked at in more detail with the National Surgical Quality Improvement Project. In this study published recently, the NSQIP database, there were 5,000 patients over a 2-year period, and they were grouped into patients that had received no bowel prep, a mechanical prep, or a mechanical and oral antibiotic prep. And the results of the study were pretty profound. This doesn't come up very well, but you can see that the no bowel prep as far as surgical site infection, ileus, anastomotic leak, and 30-day mortality were all higher, whereas the lowest were in the patients that had mechanical bowel prep followed by antibiotics. Indeed, this proved to be true on a multivariate regression as well, is that antibiotics and a mechanical bowel prep had about 50% reduction in anastomotic leak compared to patients without a bowel prep or those without antibiotics. So I always do a full bowel prep with oral antibiotics, the Nichols prep, if I'm anticipating any likelihood of needing to use colon. One of the most common long-term complications has to be ureteral stricture from the ureteral anastomosis to the intestine. There are two main ways of anastomosing the ureters to the intestine. One we refer to as the Bricker, which is a simple anastomosis on either side of the intestine between the right and left ureter. And the other is a Wallace. The left ureter is obviously brought over to the right retroperineum. The ureters are then affixed to one another with 5-ovicruals being sewn along the inside with a running suture. And then a double arm suture is passed from out to in at each apex of the ureteral spatulation, and the ureters are tied in a horizontal mattress suture. The double arm suture is then passed from in to out at the mesenteric side of the bowel and tied in place. And then the medial side is run up the ureteral anastomosis and tied. Then the lateral side is run, stents are placed, and the ureters are trimmed, and the anastomosis is completed. What are some risk factors for ureteral stricture after urinary diversion? This paper in 2017 was an excellent paper from Germany. It looked at 953 patients. It was from a single center. The median follow-up was 65 months, and the ureteral stricture rate was quite realistic at 11.2% overall. They broke this out into patients that had pre-cystectomy hydronephrosis, so those patients that had obstruction of their ureters, presumably from tumor, scarring, etc. And they found actually hydronephrosis, which is not intuitive. You would think if it was wide open, it would have a less chance of stricturing, had a much higher rate of stricture at 19% versus about 7 or 8%. They also found in this study that those that had non-refluxing anastomoses, which were Leduc, had a higher stricture rate at 10% versus a Wallace, which had a 3% stricture rate. So is it successful to fix these? It's very successful. It is not easy. 124 patients in this study with 151 reimplants, so obviously some bilateral cases, and they showed a 93% success without having re-interventions or stents, etc. A pre-op stent was associated with failure, so a lot of periureteral inflammation perhaps leading to failure, and from the paper they recommended putting in nephrostomy tubes. There was a 12% high-grade complication rate, however, and a lot of times the butt end of the conduit ends up sitting right on the vessels. So there were vascular injuries and then inadvertent enterotomies where the small bowel gets stuck down in the pelvis, and this can be really a challenging case. One trick that can make this a little bit easier is I adapted this from something about pediatric megaureters, but you don't need to disconnect and completely reimplant the ureter. So you could substitute the bladder here for the conduit, and you can just cut into the side of the dilated ureter and do a side-to-side anastomosis between the intestinal segment, and the ureter, and this works quite well and can simplify the surgery. So another specific complication I'll talk to patients about is hernias. So the problems with hernias is they can be painful, but they're different than general surgery. They do cause problems. They cause silent obstruction of the kidneys often, urinary tract infections from stasis, a poor fitting appliance that can lead to skin breakdown like you see here, and here you see the clear bulge of a large peristomal hernia. So this is an example of what we typically see with hernias. You can see the loop of bowel coming up into the hernia, and then down here you see the conduit, and it's really been squished over by the hernia, and it's very dilated, and there's a lot of hydronephrosis above this. So looking at peristomal hernia after cystectomy, they are very common. A recent systematic review identified 12 articles, most were low level, but the overall hernia rate was 17% in these 3,200 patients. The hernia was most often detected on an oncological follow-up, and when it was detected on oncological follow-up, it was up to 35% as opposed to symptomatic hernias. So there's a lot of silent hernias. The range for a clinical exam was only 4.1 to 28% in the studies. You can move the stoma. Here's a case you can see on the top side of us closing a stoma site. My experience with this is that generally people just get a hernia on the other side. And so often repairing the hernia, if feasible, seems like a better option than moving the stoma. This is what it looks like. Here you can see permanent suture repairing the hernia. We use Prolene suture. This is a colostomy that's being switched to a colon conduit, and here's a ureter being plugged in. Over on the right side of the screen, you can see the hernia mesh, and this isn't a synthetic mesh that we use. We use a biologic, which is acellular porcine dermis, and that can be sucked up underneath and reinforce the hernia site, which I'll show you. We cut out a keyhole in order to fit around the stoma. This is what it looks like. We always orient the keyhole opposite of the hernia. The hernia is over here and repaired, you can see. And this is being sucked up against the back wall as an underlay. Sutures have been placed around it to keep it in place. These aren't strength sutures. And then you can see the reinforcement of this very tough material. After all, pig skin was used to make footballs. So next I'll be talking about the right colon pouch, or the Indiana pouch. The general concept is creating about 25 centimeters of ascending colon, opening this longitudinally and folding it back, creating a rough sphere, and then narrowing the terminal ileum so that you get a catheterizable channel, and reinforcing the ileocecal valve so to prevent incontinence. This is the narrowing of the ileocecal valve with a GIA stapler. So what are the specific complications for a right colon pouch? We looked at this recently in 53 patients that did not have radiation, had not had prior urinary diversion. There are common claving grade 3 or higher, similar to the ileoconduits, 22%, and there was a very high reoperation rate. Any reoperation in the long term was 53%, and major reoperation where we entered the abdomen was 32%, so much higher than an ileal conduit. Incontinence, however, was quite rare, only occurring in 5% of patients. The total reoperation rate shown here, about 50% at 2 years, as opposed to 25% for ileal conduits. So what about neobladder? What are some specific neobladder complications that we are concerned about and need to talk to patients about? One of the big things that's a surgical concern is the complexity of neobladders. And this was a very nice study published in the last couple of years from OHSU or Oregon, where they looked at a porcine study of a simplified neobladder. And I think the motivation for this is robotics, where any simplification of the surgery can lead to speedier surgery because of the complexity of robotics. And so they just brought a simple U together, and they looked at urodynamics in pigs compared to a Studer and a Kami pouch. And the advantage of this also is that it creates an orthotopic ureteral reimplant. So it's quite a nice pouch. Another advantage is it creates a greater length for the urethral anastomosis. When you create a circle or the other configurations that you can create with a neobladder, your egress into the pelvis is restricted by the shortest aspect of the mesentery. With a U, you can pick the point that you have the greatest egress into the pelvis and the most laxity in creating the urethral anastomosis. So this is a concept or drawing of the neobladder, and it's a double limb U pouch. So here's a U, and then you have a chimney that goes up to meet the orthotopic ureter anastomosis. And these were the favorable urodynamic profiles, with the double limb U pouch consistent with a Studer pouch. This is what it looks like. Here's your U going down into the pelvis. We open up the U antimesenteric other than this small chimney on either side that'll go up to the ureters. So what does it look like afterwards with a cystogram? We call this the devil pouch because that's what kind of looks like a demon devil with these two limbs going up to the ureters. One of the big concerns for patients is the need for catheterization. It can be painful to catheterize the urethra, and patients have to be committed or have experience to self-catheterization. This was from USC, which arguably has some of the best data about neobladders out there. They looked at 299 patients, and they really looked at who used catheters. And 17% of the overall cohort had to use catheters. 7% had to use them all the time. However, the stories, that doesn't sound too bad, but the story I don't think is really complete until you look at their data at 5 and 10 years. And there's a dramatic increase over time in the need for catheterization. At 5 years, it was 23%, and at 10 years, it was 38%. A third of patients needing catheters at least some of the time or all the time, you better count on needing to use catheters at least somewhat. Another big concern is continence, and this is where I think neobladders fall down a little bit. This was from the same group, published 4 years ago, 188 patients, and they used patient-reported outcome measures. They looked at 12 to 18 months. However, the other story, I think, really can lead to bad quality of life, and it's nighttime incontinence, which occurs in up to 50% of patients. So to summarize, what are the patient and surgeon concerns? Obviously, everyone's concerned about death with the operation. Long-term operative complications. The best is neobladder. I didn't show you any data about that, but there's some evidence. It's about 15% intervention rate for neobladder, about 20%, 25% for conduit, and then the 33% or higher for right colon pouch. What about the ureters? I think that for a conduit and a colon pouch, the ureters are brought over to the right side of the abdomen, and that increases the risk for stricture. So I'd say neobladder wins there. For hernia, conduit and right colon pouch are worse for hernia, especially a conduit, where it's a very common complication. With neobladder, patients should be just exposed to midline hernia, which is common, but if you add that and a peristomal hernia, it's a very common event to get a hernia problem. Continence. You can have some problems with continence with a conduit, with a poor stoma, with patients that are not very sophisticated or can't learn how to use it. Right colon pouch, however, the continence rates are excellent. Neobladder, I think it's a huge concern for patients, and they have to know that they may even need diapers overnight to treat their incontinence. Very important point of all this, though, there's almost no evidence showing any difference in patient satisfaction between any of the different diversions, and that's really important to emphasize. Choosing the right diversion for the right patient is critical to their satisfaction, and it's really a process that needs to be facilitated by the clinician, taking into account the patient's preferences and their values. There's no other way to make a decision like this. It's a very tough decision for patients. Well, I want to thank you so much. I hope that this was a helpful talk, and I certainly enjoyed putting it together for the Philippine Urologic Association and for TOTO and the Philippines Genitourinary Reconstructive Society. It's really been a pleasure and it's an honor, and I hope to meet you all in person. Hello, my name is Jeremy.
Excellent lecture, Jeremy. That was a great lecture, especially the last slide. I will be using that slide for reference when I talk to my patients every time. Thank you very much. We will discuss that later in the Q&A. But I would also like to remind the audience that you can join in anytime in the chat box. So we have a health discussion going on in the chat box. And we will also talk about it later during the Q&A portion. Now let me introduce to you our next speaker. Can you please present up pictures slide? Dr. Sean Patrick Elliott completed his fellowship in genitourinary trauma and reconstruction at the University of California, San Francisco. Currently, he is a professor at the University of Minnesota and serves as its vice chairman of urology and the Director of Reconstructive Urology. He also served as a past member of the Board of Directors of the Society of Genitourinary Reconstructive Surgeons. Ladies and gentlemen, let's all welcome Professor Sean Patrick Elliott.
Thank you for inviting me to talk at the Art of Urinary Diversion conference. I think it's a fantastic idea. I'm really glad to see such interest in urinary diversion. I work at the University of Minnesota, which is in the northern part of the United States, not just a few hour drive from Chicago. And a lot of what I do is take care of people with radiation complications, and that's what I'm going to be talking about today. This is a photo from about 1975 or 1976, and I'm the guy there on my dad's lap, and I show it to you because this is not my first time in the Philippines, although today I'm only here virtually, but back in 75, 76, my dad was stationed at Subic Bay in the Philippines, and he really remembers that time fondly, and I don't remember any of it, so I'm sorry. So today we're going to talk about is that first, radiotherapy urologic complications are quite common, more common than you'd think. Second, we'll talk about some differences between prostate cancer and cervical cancer radiation and how the complications present and how the cystectomies go. I'll talk to you about how reconstruction can be difficult after radiation. And so sometimes we do have to do urinary diversion. And then what you really want to hear is perhaps some operative tips that I might be able to share about how I do a cystectomy after radiation, and maybe some of the things that I've learned might help you. It's really impressive to think about how many cancer survivors are survivors of urologic cancer or other cancers in the pelvis. In men, over 50% of all cancer survivors had some type of urologic cancer. And in women, if you also include cancers in the pelvis that aren't urologic, pictured here in orange, they also have very high rates of pelvic cancers. And so together, it's something like 50% of all cancer survivors have some type of pelvic cancer. And of those people, somewhere close to 50% of them have gotten radiation as part of their cancer therapy. So if you think about it, somewhere between like 20 and 25% of all cancer survivors have had radiation as part of their cancer therapy. And that's because radiotherapy is a really important part of pelvic cancer care, but it also means that we stay busy taking care of radiation cystitis and a lot of the other problems I'll talk to you about today. I'm going to show you that the radiation therapy complications continue to accrue over a long time horizon. And that's because radiation damages the DNA of actively dividing cells. This damage is cumulative over time. This results in fibrosis, and it also results in endarteritis, so that you get tissue hypoxia. The mucosa of the bladder in particular receives poor blood supply after the radiation, and thus it starts to form all of these other glomerular blood vessels in the submucosa that then lead to the picture that you see here. These new blood vessels are, friable and they bleed easily. So it doesn't matter what type of cancer they had and what kind of radiation they got for their cancer. And of course, the answer is yes. We'll talk about cervical radiation first and then prostate. And this dose treatment planning CT scan here pretty much tells you the whole story. The dosages these women get are over 100 gray, and the field of therapy is extremely wide. Now, it has to be that way because cervical cancer can be very bulky. T4 disease is not uncommon. but it gives you an understanding of why we see so many complications. We used a national data set in the United States called the SEER Medicare data set to track these women over time and measure all the complications that they get. And this Kaplan-Meier curve on the left shows you the cumulative incidence of adverse events after cervical radiation going out to about 12 years. And we only counted those events that required some type of intervention, like a surgery or a stent. And so we call those grade 3 or Clavian grade 3 complications. And it's about 30% at 10 years. And you can see that the most common complications are happening in women who got either radiation plus surgery in yellow or external beam radiotherapy plus brachytherapy in blue. So can we just blame it on the radiation? I have to say no, because as I said earlier, these women have very bulky tumors. Very bulky tumors, and this leads to having to have pretty broad doses of the radiation. There's really few reconstructive options after the cervical cancer radiation. You know, for ureteral strictures, you can place a stent or a nephrostomy tube, but you can't do a ureteral reimplant. It won't work. So you're really stuck with an ileal ureter or a cystectomy if the bladder's not any good. Similarly, for other complications like a small contracted bladder or radiation cystitis or vesicovaginal fistula, vesicorectal fistula, vaginorectal fistula, urethral stenosis, a lot of these things end up with cystectomy if you can't manage the symptoms in other ways. We looked at our outcomes from cystectomy for women who had the cystectomy done because of complications of radiation. These weren't cystectomies done to cure them of cancer. They had their radiation for cancer years ago. Now we're taking their bladder out or giving them a diversion to treat the complications of the radiation. And actually, two of the co-authors on this paper are here on the panel with me today. Dr. Stoffel and Dr. Myers contributed their patients to this paper. So we had 34 diversions, about half of them for fistula. Most of them got some type of a conduit. And at the bottom on the left, you can see that about half of them, we didn't even bother doing a cystectomy. We just did a diversion because they had no outlet resistance in the urethra. They were not going to get pyocystis. And then the rest of them, we either did a total cystectomy or a supratrigonal cystectomy. And then in terms of complications, within a month, about a third of these women got readmitted to the hospital. And almost a third of them had a Clavian grade greater than or equal to 3 complication. We couldn't figure out any predictors of the Clavian 3 complications. And then we looked at their long-term complications. And as you might expect, ureteral stricture, but pretty high rates, 15%, some type of stoma complication in 15%, and then a pretty high rate of some type of fistula, often a bowel fistula from the bowel anastomosis. And we'll talk more about bowel anastomosis later. The prostate radiation we'll talk about next. In the United States, most men don't get external beam radiation in the classic sense anymore for prostate. They get IMRT. The IMRT beams come from multiple different directions and helps us spare the rectum. But as you can see on the right, even though the rectum is getting spared, the urethra is not. The urethra is here in the middle of the prostate in red, and the rectum is back here and it's spared. And when you look at the rate of urinary toxicity, it's identical between IMRT and 3D conformal radiation therapy because the urethra is just not spared. They've got these rectal spacers to try to protect the rectum, but it doesn't protect the urethra. The rectal spacer there is in white, and the bladder's in yellow, and the rectum's in blue. In fact, I would postulate that the spacers, just like IMRT, allow them to drive up the dose of the radiation, and then that actually hurts the urethra and bladder even more. We use the SEER Medicare data set to look at the cumulative incidence of grade 3 complications after prostate radiation and surgery, just like we did in the cervical cohort earlier. And you can see the rates are, again, about 30% at 10 years. And that radical prostatectomy plus EBRT had the most complications, followed by brachytherapy plus EBRT, and then radical prostatectomy. Most of these complications are urethral strictures, bladder neck contractures, and then less often radiation cystitis. Strictures and fistulas after prostate radiation. It's a really difficult decision regarding when to reconstruct them, when to palliate them with something like a suprapubic tube, and when to divert them. We're not going to talk so much today about the reconstruction because we're talking about cystectomies and diversions. But the reconstruction is usually a urethroplasty. So when do you do a urethroplasty and when do you do a diversion? Well, some of the things I think about that drive me towards cystectomy, obviously if they've got a stricture plus radiation cystitis, cystectomy. Pain or calcification in the tissues, that usually indicates necrosis from the radiation. Oftentimes that gets better with hyperbaric oxygen therapy, and I use that a lot, but when it doesn't, that usually drives me towards cystectomy. If they've got a necrotic cavity in the prostate, like this man does here, this is a cystogram, and the contrast is just filling this big cavity where his prostate used to be. He had brachytherapy plus EBRT and then multiple transurethral resections of necrotic tissue, and now he's just got a cavity there. That's not going to be a good urethroplasty, even though his urethra looks great. So he's going to have a cystectomy. If they've got multiple kinds of radiation instead of just single kinds of radiation, more likely to end up with a cystectomy. If they've got a very long stricture, that's less likely to be good for urethroplasty. Or if they've got a very large radiated fistula, or if they're also incontinent, all of these things would drive me towards cystectomy. So let's look at an example of 3 different men and how we managed them. Which ones did we do urethroplasty on? Which ones did we do cystectomy on? And honestly, at first glance on the x-rays, they all look like they're reconstructible. So let's go through their histories, and I'll help you, I'll walk you through how I thought about it. First off, you always want to place a suprapubic tube in these men with posterior urethral strictures after radiation or after radical prostatectomy. What it does is it allows me about 4 to 6 weeks later to go in with the scope through the suprapubic tract, look at the bladder, see how healthy the bladder is, look at the prostatic urethra, if the prostate's still there, see how healthy that is. I like I did in this man, I like to see it healthy all the way down to the verumontanum. So now I know in this man that he's only got a 2 centimeter stricture. We did a urethroplasty on him. We never had to do an artificial sphincter because his bladder neck is intact and he's continent. Now this man, at first, I thought that his posterior urethra looked relatively healthy. This looks open. But once we put the suprapubic tube in and then did the antegrade cystoscopy, I could see that this narrowing here was actually a 5 French stricture. So now I'm talking to him about, should we do a cystectomy, or is he really motivated for me to do basically a prostatectomy and then anastomose this pretty healthy urethra here all the way up to his bladder neck, and then he'll need an artificial sphincter for sure. The last man who had radical prostatectomy plus radiation, his stricture doesn't look that long, right? I mean, it's just 1 centimeter or so here. His bladder neck looks pretty healthy, but this man came into my clinic crying in pain, in tears, and on narcotics. And he has constant hematuria and he's incontinent. He's got terrible radiation cystitis that did not improve with hyperbaric oxygen. So he ended up with a cystectomy, even though his stricture doesn't look that bad. Oh yeah, so here's some circles showing how long their strictures were and how we managed them. A few words about anterior fistula, because I think it's a good kind of new topic to talk about. Everyone knows about rectourethral fistula, but these are fistulas from the urinary tract to the pubic symphysis that I'm talking about. Almost all of these men have had radiation plus transurethral resection, which results in a capsular perforation of the prostate or the urethra at the bladder neck anastomosis after radical prostatectomy plus radiation. They have this leak, and then the leak doesn't heal because of the radiation. In one series, almost all of them got a cystectomy. There are reconstruction options in ideal candidates, but most of them end up with cystectomy. The diagnosis is often delayed for a long time because their presentation is atypical. They present with recurrent UTIs. They very rarely have the classic picture of redness in the skin over the pubic symphysis and pubic bone tenderness. More often what I see is the elusive finding that you have to look for, which is pain with hip adduction, because the adductor muscles insert into the pubic symphysis. Some of them will have pain with ambulation. I've had some of these men come in to my clinic in a wheelchair just from pain. CT scan's not very helpful. MRI is what we use for diagnosis and surgical planning. So to diagnose it, look at MRI on T1 and T2. On the left, you've got T1. On the right, you've got T2. T1, bone marrow and fat are going to be bright. So bone loss is going to be black. And in all of these x-rays here, I'm going to show you the healthy bone in maroon, and then the poor bone or the dead bone, the infected bone, in yellow. So you can see that the healthy bone has bright white bone marrow, and the dead bone or the infected bone is black. On the right side, you see a T2. Now in T2, fat is still bright, bone marrow is still bright, but so is water. And so on T2, urine leaks and tissue edema will look bright. So in this one, we've got the affected bone there in the middle, which is bright because it's been infected. And then you've got the urinary spread all over and all this edema and infection going all over his pelvis. How about if you want to see the fistula itself? So on the left one, this is an axial image and then a coronal image of the same man. And what you see is that the posterior urethra is in yellow there, and you can follow the brightness going in between the pubic symphysis, and that's his fistula. And then the same man on the bottom panel, you can see pubic bone, and then in yellow, you can see the fistula with all the brightness there on T2. And on this other man, you might recognize his MRI from a couple slides ago. He's got a large cavitation defect where the prostate used to be, and it's just a mess filled with clot and dead tissue and some calcified tissue. So in the end, it's really the cavitation defect and the bladder function, not necessarily the degree of osteomyelitis, that drives the choice of reconstruction versus cystectomy in these guys. So next, let's talk about how we go about doing a cystectomy. The post-radiation cystectomy is really challenging due to the lack of anatomical planes. So here are my guiding principles. First, always place nephrostomy tubes if there's any suspicion of ureteral stricture. You don't want to operate on these men with the ureteral stents in place. In one study at the University of Chicago, they had much lower ureteral restricturing if they put in nephrostomy tubes first. And that's because the level of stricture will declare itself once there's not a stent in there, and sometimes you'll be surprised how high up the stricture goes. Second, keep the dissection close to the pubic bone and the pelvic sidewall. Avoid the temptation of staying in close to the bladder, because actually the bladder, because of the radiation, the bladder's kind of sucked up out against the pelvic sidewall. And so you really, I usually use a bovie for this dissection, and I really use the bovie to like scrape it off the backside of the pubic symphysis or sometimes I'll use a cob, which I'll show you a picture of in a few minutes, to scrape it off the backside of the pubic symphysis. And then when you go out lateral, people get afraid of the obturator nerve and the external iliacs, but honestly, I've never injured them. You want to stay lateral, because if you start going medial, you'll be surprised. The levator muscle does not bleed as much as the detrusor. If you get into the detrusor muscle after radiation, that can really bleed. So stay out lateral, even if you make a hole in the detrusor muscle. I'm sorry, even if you make a hole in the levator. Now, one thing to point out is when you get to the iliacs. So this cartoon here demonstrates a normal bladder, the internal iliac or hypogastric artery, and then a branch going to the bladder, the main bladder pedicle. And after radiation, the bladder shrinks down. But something I've discovered the hard way is that the parts of the bladder that are anchored to the blood supply, they don't shrink down. So as you go around with your bladder dissection, you're of course going to want to stay away from the vessels because you don't want to get into major bleeding, but avoid the temptation of going too medially, because there's always these two horns of bladder that stick up towards the blood vessels. And way too many times I've cut across the bladder, like right about here, and then you're leaving this mucosa behind, which I'd rather get all of it out. Speaking of getting all of the bladder out, the one place I don't get all of the bladder out is on the rectum. I'd much rather leave a little bit of bladder on the rectum than a little bit of rectum on the bladder. So leave a little bit of bladder behind. It's usually no bigger than the size of like a quarter, a US quarter, and then you can cauterize the mucosa afterwards. Also, avoid a bowel anastomosis whenever possible. So this comes up in people who you're either going to make a colostomy for them during the cystectomy, or maybe they already have a colostomy. So what you can do is you can take that segment that is going to be the colostomy or is already the colostomy, you can divide it about 20 centimeters below, and that will now become your new urinary diversion. You wash it out, and the old colostomy becomes the new urostomy. You take this proximal segment and you bring that up to the other side as a new colostomy. And so that usually means that the urostomy might be on the left side and the colostomy on the right, if they used to have a colostomy on the left. Avoiding a bowel anastomosis in these radiated people helps avoid some of the worst complications. The fistulas only, the bowel fistulas and anastomotic breakdowns, they only happen in a few % of people, but when they happen, it's really bad. My last piece of advice is if it gets hot working in the sun, then go sit in the shade for a while and come back when it's cooled off. And by that, I mean, if the dissection is getting really difficult, don't persist in that area. You're probably just going to make an error. I certainly have. Go somewhere else where it's easy. You can always come back to the hard part later. Next, what kind of cystectomy you do depends in a large part on the type of previous prostate cancer therapy. So we're going to go over them from kind of easiest to hardest. So I would say the easiest ones are those men who've had brachytherapy plus EBRT. They have radiation cystitis, but they have a very healthy prostatic urethra. Now, I'm not showing you men who've only had brachy because usually they don't end up with a cystectomy. But brachytherapy plus EBRT, radiation cystitis, but a totally healthy prostatic urethra. First, you want to ensure that there's no stricture, because if there is and you leave the prostate behind, you could get some pyocystis. But if there's no stricture, these go pretty well because the bladder is usually not too scarred to the surrounding structures. You can leave the prostate in place and you can do a subtotal cystectomy. So in this silly cartoon down here, the bladder is in yellow and the prostate's in blue. You can use your bovie to remove most of the bladder. You can leave the trigone posteriorly and about 3 centimeters of an anterior bladder flap. And then you can fulgurate the mucosa. There it is, fulgurated, now it's maroon. And then you can close that little bit of bladder apex. And as long as there's a good prostatic urethral outlet, there's no stricture here, this will do just fine. And the nice thing is now you haven't had to deal with the rectum, because it's the prostate that will be stuck to the rectum. The bladder won't be stuck to the rectum in this case. And there's also going to be minimal or no urethral leakage. I'm sure you guys have all had these patients that are annoyed by this discharge they get out their urethra, especially if they've been radiated before. And this discharge can last 3, 6 months or forever. And this guy won't have it because he's not going to have a urethral stump. He has his urethra closed off to the outside world. So if there's prostate necrosis, it's quite a bit harder. So in these men with a necrotic prostatic urethra, where it's really just a dead cavity, I do a cystoprostatectomy because if you don't, there's going to be a bad infection. The prostate can really be like an empty eggshell, almost like someone took an egg and made a little hole in it and sucked out all of the egg from the inside, and you just got an empty shell. And you get into this cavity really easily. The bladder comes out easily, and then you get into this necrotic cavity. It's impossible to remove this necrotic cavity all in one piece. It comes out in pieces. It's difficult. This is where you can leave a little bit of prostate on the rectum. You can use a cob, which is this instrument shown here, to scrape some off the posterior symphysis. You usually cannot close the urethra, so they do get drainage out the urethra. Post-op infection happens too often. They get pelvic abscesses or purulent urethral drainage, even pubic osteomyelitis. I stuff omentum down there. I scrape everything out I can, and then I hope for the best, and I place drains. The toughest cystectomies, I think, are those who've had radical prostatectomy plus radiation, because once the bladder's been mobilized previously by the radical prostatectomy, and then it's been radiated, and the bladder's been brought down over the rectum to anastomose to the urethra at the pelvic floor, it's stuck to everything, including the rectum. So these are the hardest cases. And in these, you really have to pull out all the tricks that I showed you earlier. And in these, you definitely want to stay right on the pubis and the pelvic side wall. And then that little trick I told you about, the 2 horns of bladder that go up to the vessels on both sides. And here you definitely want to leave a little bladder on the rectum. The urethra, again, can be hard to close. Let's talk about the role of the transverse colon conduit. So everyone always thinks that you do a T-colon conduit because you have compromised small bowel from radiation. And indeed, that's one good reason. But you also can do it when the ureters are compromised. It's really easy to bring the T-colon all the way up to the renal pelvis. It's a little harder to do that with ileum, although you can. There's 2 ways to do a T-colon conduit, and this cartoon I put together here shows it pretty well. You can either harvest the conduit, drop it below the intact colon, and then do your bowel anastomosis above. I call this an intraperitoneal T-colon conduit. And then the ureters will have to be brought through the right and left colonic mesentery to anastomose to the T-colon conduit in the midline. This is good if you can anastomose to, say, like the mid or upper ureters. If you really have to go all the way to the renal pelvis, then you have to do a retroperitoneal T-colon conduit, I call it. And so here you harvest the T-colon. This time you flip the T-colon up on the patient's chest and you bring the bowel anastomosis below that. And now you can anastomose directly to the renal pelvis on both sides because you're totally retroperitoneal. Last slide or 2 here. We looked at our series of about 100 cystectomies for prostate radiation complications across a multi-institutional group called TURNS. And the take-home point here is that they also have many complications, but not as many as the cervical cancer patients. So here, about 1/3 had grade 2 complications. With cervical radiation, about 1/3 had grade 3 complications. And then the other take home is that with cervical radiation, about 1/3 got readmitted just in 30 days. Here, about 1/3 get readmitted out to 90 days. So the prostate cystectomies go quite a bit better than the cervical cystectomies. So in conclusion, radiation complications continue to accrue over the long term. Not all injuries after radiation are reconstructible. Some result in diversion. cystectomy for radiation complications has a higher complication rate than cystectomy for just cancer. We talked about the cystectomy tips, which were stay lateral, stay off the rectum, and use omentum. And then we talked about the diversion tips, which were place pre-op nephrostomies, avoid a bowel anastomosis if you can, and avoid radiated bowel, like with a T colon. Thank you.
Thank you very much, Sean. I have to admit, you mentioned a lot of things there that I have never even considered in my private practice. So these things I've learned now, and I will definitely consider them in my practice. Now, for our next speaker, I'd like to introduce to you Dr. John Thomas Stoffel. Can you please put this slide on? Dr. Stoffel completed his fellowship in female neurourology and reconstructive urology at the University of Michigan. Currently, he is a professor at the University of Michigan and serves as the chief of the Division of Neurourology and Pelvic Reconstruction. He is also the president of the Neurogenic Bladder Research Group, or what we know as the NBRG. Ladies and gentlemen, he's going to present his lecture live. I present to you Dr. John Thomas Stoffel. John, go ahead, John.
Well, thank you very much for this opportunity. It's a great honor to present to this group here, and congratulations on your celebration of outstanding urologic care in the Philippines over the many years. I'm going to share my screen here. Okay. And so thank you again for inviting me to talk to this group. This is a subject that is very near and dear to my heart. I see a lot of neurogenic patients, and I'd like to echo a lot of the themes that have been said earlier, that this is something that requires just a tremendous amount of investment from urologic minds and hearts. And I think that what I'm going to focus on here today is really maybe more of a plea to understand what needs to be considered before getting to cystectomy, as much as the ultimate technical considerations for it. Since I'm going to be giving this talk live, maybe I would ask Professors Martins, Myers, and Elliott to field some of the questions that may come up during it, and we can discuss afterwards. And so we'll start. I'm from the University of Michigan. This is in the center of the country here. And just as an aside, it's just starting to warm up here. It's been between 0 and 10 degrees Fahrenheit here. So I'm vicariously traveling to warmer places through this conference. So thank you. We also see, similar to Dr. Myers, see a catchment area from a somewhat rural group of people, particularly in the northern part of the state. And so kind of the echoing of the themes a little bit of communication and discussion is really paramount in the care of these patients. And so when I'm thinking about these patients, I tend to think about two big buckets, and this is safety and quality of life. I think most of the issues concerning neurogenic bladder can pigeonholed into these two big subjects. When we're thinking of safety, really think about protection of the upper tracts. Are they going to get renal failure? Are they going to have infections? Are they going to ultimately lose function of their kidneys over time? I think a lot about infections. How can we avoid and prevent urinary tract infections specifically? Urinary tract infections, as we'll talk about in a bit, have tremendous impact in the neurogenic bladder population. And so it's something that urologists can be chiefly involved with. For safety, I think about soft tissue protection. Incontinence in somebody who's in a wheelchair has much more severe impact than somebody who's ambulatory. You can end up with sacrodecubitus ulcers and skin breakdown, and it can be a devastating complication. So we think a lot about how can we protect the tissues that the patient has pressure points on. And then an underappreciated aspect of safety, I think, in neurogenic patients is autonomic dysreflexia. Autonomic dysreflexia can cause significant health concerns from cardiac to from other cardiovascular. And it's something that I think is also underappreciated, and is also an element that urologic care can make a huge difference in these patients. For quality of life, I think this is also maybe an equally important bucket that needs to be discussed for these patients. Satisfaction with bladder management is really paramount. very different than maybe the radiation patients or some of the cancer patients. These patients have options. And so when understanding really how they manage their bladder can really make a big difference in their quality of life. How much time do they spend catheterizing? What resources do they need to be able to get to the bathroom? How are they planning their day around emptying their bladder or managing their urinary system? And the variable of time, how much of time is devoted to the care of their bladder, is really something that's impacting their quality of life. And so maybe a little bit different compared to the other talks here. The quality of life, I think, is something that may be driving decisions towards cystectomy in these patients on much more an elective basis, as opposed to some of the critical medical issues that we saw in Sean's lecture earlier. All these two things of safety and quality of life really contribute to the health and happiness of this population. I'll also kind of introduce the concept that neurogenic bladder is not a single diagnosis. I would say that we don't look at cancer and say all oncologic patients have cancer. They have individual diagnosis. And similarly, neurogenic bladder is very much like this. If you look at this diagram here, see how the different diagnoses affect different parts of the central and peripheral nervous system. Think of Parkinson's. There's an excellent lecture earlier talking about beta-3 agonists in Parkinson's disease. Parkinson's is a slowly progressive condition. Spinal cord injury, very different. It's a traumatic single event that causes a dramatic instantaneous change to the neurologic system. Spina bifida is different. It's a congenital effect that created a hardwire change within the nervous system very early. All these things really contribute to how we look at the patient, what the expectations are, and really how they are responding over time to care. And I think this is how I kind of think a little bit about how do we get to cystectomy in these neurogenic bladder patients. I think the natural history of the disease is paramount. Think of, for example, a multiple sclerosis patient. Somebody with primary progressive disease is progressing very rapidly. They may not actually benefit from a cystectomy because their disease will progress too rapidly to really reap the long-term benefits. Spinal cord injury patient is very different. They have maybe a much more longer quality and quantity of life expectation. This informs the testing strategies. What's their cognition? How are they able to participate in studies? And also, what's the frequency of it? A spinal cord injury patient has probably a very different testing strategy than a Parkinson's patient. We need to think a little bit about how the disease evolves over time and what their capabilities are. These things further add into their surgical risk and benefit. I think loss of cognition and progression of disease is something that needs to be considered in some of these neurologic patients. Again, a multiple sclerosis patient may actually have disease progression from a maximally invasive surgery, whereas a spinal cord injury patient may not. So these things are things to really strongly consider when thinking about getting to cystectomy and kind of how is this going to impact on their safety and their quality of life. So what we're going to talk about here today, again, is how do we get to cystectomy in this population? I want to talk a little bit more of the drivers of safety and quality of life. Then I want to touch on some of the outcomes of diversions. I think we had outstanding technical talks from Dr. Myers and Dr. Elliott, and I'll tell you, I learn something every time I hear talks from them. And so I'm going to focus less on the technical aspects of how to perform surgery in these, and maybe more some individual considerations about like what to do with the bladder, what to do with the bowel afterwards. So let's talk about detrusor sphincter dyssynergia, or DSD. As mentioned before, this can be a significant safety concern in the neurogenic bladder population. Who gets DSD? It's prevalent in spinal cord injury patients, multiple sclerosis, and spina bifida as the three main groups. In spinal cord injury, it really is associated with a different morbidity overall and with urinary symptoms specifically. There is a good study in 2017 looked at spinal cord injury patients with T6 or above lesions, and really kind of to summarize, showed that there is a strong change in the bladder physiology in people with autonomic dysreflexia, and they do have increased voiding pressures, which resulted in more urinary symptoms and more safety issues that occur, specifically urinary tract infections. Multiple sclerosis, by contrast, these patients do have detrusor sphincter dyssynergia, but it's really unclear as to actually whether or not this causes dangerous physiologic changes in the bladder. The Diseases group did a nice review in 2007, did a meta-analysis of the existing data, and it concluded that yes, patients with DSD did have upper tract changes over time. more data, particularly from the United States at the University of Texas Southwestern and our group at the University of Michigan, we really did not demonstrate a strong association between DSD and upper tract changes in MS patients. This may have to do with evolving MS care and different kind of assumptions of it, but it's something to note, but maybe not necessarily drive changes or drive immediate need for cystectomy and for multiple sclerosis patients. Spina bifida patients, very strong relationship between DSD and renal deterioration. This was shown by David Bloom, Stuart Bauer, nice review in 1998 by Kurzak to be able to kind of review some of these changes. So what exactly is DSD? Very briefly, I think we tend to look at it as a binomial variable, as whether you have it or you don't based on EMG or by VCUG. We looked at actually urethral closure pressures in a group of MS and spinal cord injury patients, and you could actually see changes in the proximal urethra at the sphincter. And I would kind of suggest that anything where you see above about a 20 centimeter water pressure change in the proximal urethra near the sphincter during voiding is really indicative of DSD. And this study that we looked at, it showed very close association with this 20 centimeter water change with EMG and also with VCUG. So the next safety issue that I'd like to talk about is bladder compliance. Now, bladder compliance essentially, as we know, is just how stretchable the bladder is. It's the change in volume over change in pressure. So it's a calculation. What I'm showing here is a pressure curve of pressure versus volume of normal compliance in the bladder. There's a small raise in pressure when the bladder initially fills with some of the elastin is starting to stretch out. But then you notice that there is a very flat change where there's no pressure changes for large increases in volume, which is the stage 2 of filling. That's normal compliance. And normal compliance is hard to define. There's no really great studies that show a true number, but back of the thumb, anything greater than 15 milliliters per centimeters of water is considered normal compliance. And really, most patients who have no underlying problems, the number is closer to 40. So low compliance, though, you see large changes in pressure for small changes in volume. So pressure has to go somewhere. You're starting to see pressure driving into the bladder with very small changes in filling. This is low compliance, and again, compared to normal compliance. So when you're thinking about compliance, why is this important? Well, pressure has to go somewhere. And ultimately, pressure has to go somewhere. And if it doesn't come out as incontinence, it can ultimately cause upper tract changes. And that's why we worry about it so much. And so what are the causes of low compliance in a neurogenic bladder? Well, you can start to see contraction against a fixed bladder outlet with intrusive overactivity in DSD. And that's why DSD may ultimately be a problem with risk factors for patients. You start to see urinary tract infections driving changes in collagen, which can also cause loss of stretchability. This is something that also can very much change the compliance of a bladder. Chronic Foley changes or chronic Foley catheters also may cause inflammation. They may cause injury to the bladder. And so also they may drive some overactivity. This is something that may also alter the compliance of patients, particularly neurogenic bladder patients. As I mentioned, pressure has to go somewhere. This is a patient that we treated that had an indwelling catheter for a long period of time. You can see that this patient ultimately developed renal failure just from low compliance bladder. It blew out his upper tracts, and he ultimately needed a transplant for. So compliance is a key safety issue that we need to follow. There's some good data to show that compliance impacts upper tract risk. This is a very nice meta-analysis, 49 studies through 2017 by Musco, published in 2018. Essentially looking at, when you looked at kind of using an author definition of low compliance, patients with low compliance, the odds ratio of having upper tract changes was close to 8 in neurogenic patients. So very strong association, just even using what the authors defined as low compliance. Detrusor leak point pressure is Ed McGuire's kind of an initial concept on how much pressure needs to be in the bladder before you see upper tract changes. And using this definition, also strong association with upper tract changes. So I think there's really good evidence that patients with low refractory, low compliance bladders will develop upper tract changes. This is a strong reason to consider a more significant intervention like cystectomy to protect their upper tracts. So what's the relationship between indwelling catheter and low compliance? To be honest, it's not clear. A lot of the opinions and thoughts that we have come from the paper of Weld in Journal of Urology published in 2000. It was a very large study, nice study done. And ultimately, kind of quote from the study here is patients using intermittent catheterization had significantly higher incidence of normal compliance compared to the Foley management group. And this included urethral and suprapubic tubes. I think this has driven a lot of our decision making about trying to avoid indwelling catheters for patients and to use intermittent catheterization for them. I think, though, that I'm not sure as to kind of the true association with it. There may have been confounding factors with this group, and it's really kind of unclear. We all have sort of the complex patients that we kind of think of when we think of the horrors of complications from indwelling catheters. This is a patient of mine who had a suprapubic tube for many years, and it eroded through her abdominal wall. You can see that she essentially just had a big fistula from it. She had poor care from the catheter, and it eroded from low compliance. Another patient of mine, an indwelling urethral catheter. You're looking at the pubic bone. It essentially eroded her urethra all the way back to the pubic bone. And maybe the lesson here, the message here is that patients with neurogenic bladder managed with an indwelling catheter need compliance checks. They need frequent urologic assessment so they don't develop complications from their catheter. So very briefly, treatment for low bladder compliance, generally use anticholinergic or beta-3 agonists. They need frequent urodynamic testing to make sure that you're ultimately achieving the goal that you want. They need Botox if that's failed. There's good data to suggest improvement of compliance, in some cases up to 50% in some studies. Urodynamic testing again frequently. And with failure of those, diversion or augment, and specifically we'll talk about diversion in this case, very good option for long-term protection of the upper tracts. So very briefly, who needs initial urodynamics? If you're going to be kind of following these patients, I would argue all spinal cord injuries need urodynamics initial screening. And the reason for this is that there's no real good way at this point to de-differentiate risk in these patients. Low compliance can occur in partial, complete injuries. It can occur just about any level of the spinal cord. And so an initial urodynamic study to understand compliance of this is extremely important. Spina bifida is similar. Those patients, I think, can benefit from initial screening of urodynamics to kind of map out strategies for care. Multiple sclerosis, probably these patients don't need urodynamics initially. You can maybe use it more for clinically significant problems if you're worried about DSD or if you have a quality of life issue, but they don't develop as many safety issues. Same thing similar for most other neurogenic bladder patients. They don't really need safety screening with urodynamics. You can use it more to understand symptoms, not necessarily need to screen for safety. And so imaging is an important part of this also. With testing, you can also visualize the upper tracts, and very important in neurogenic bladder patients. This is a ultrasound that can just demonstrate a good example of intrarenal collecting system dilation, and then also coming down into the proximal ureter. It's a good way to show progression of upper tract changes, and you measure the cortical thickness and collecting system dilation. It suffers from lack of standardization. And so it's good to kind of look at these films yourself as you're following them over time, because radiologists may have a different interpretation of what they actually call chaliectasis versus hydronephrosis. And so looking at these films to develop your own internal system and tell a more standardized way to develop is a good practice. A CT is good to understand the functional anatomy, I believe. It's something that you can understand a little bit more of the source of the urodynamics and get a better picture of the anatomy prior to cystectomy. Important to remember that when you do a CT urogram, it's 1.5 times the radiation. And so maybe not the best screening study because the effects of radiation are cumulative over time. Good example of following up this patient with hydronephrosis. You can see under renal collecting system dilation. Now, if you get a CT scan, this patient had a massive bladder stone. And so ultimately, you can see the source of this from it. UTI is a considerable safety issue in neurogenic bladder patients. From our neurogenic bladder spinal cord injury registry, Irene Crescenza just published kind of prospective study from this cohort looked at their ER visits and urgent care visits over 1 year, and 17% had an unplanned urgent ER or urgent care visit. And this is independent of them calling their office for an evaluation. This was an unplanned urgent visit. And UTI is the most common cause. And strong association in this cohort following prospectively with indwelling catheter was associated with urinary tract infections and ER visits. So, UTI really, I think, does kind of address, is a safety issue for these patients. How do you prevent urinary tract infections in this group? You can avoid over distension, keep the volumes low. You can use medication for compliance, like we talked about, monitor DSD to really avoid reflex avoiding patients with high pressures, aggressively treat urinary calculi, and use a hydrophilic catheter, some data to show that this may actually reduce the risk of infection forming CIC, and a regular bowel program. All these things are very easy urologic interventions that may prevent patients from developing safety issues that necessitate cystectomy. The quality of life is something that I also like to touch on. And this is, Jeremy's touched on this very nicely in his talk, that following the patients and really looking at their symptoms is a good way to understand kind of how impacted they are by it. I would argue using a validated questionnaire is a great way to be able to look at this. A really nice one is Blaine-Welk's neurogenic bladder symptom score, measures incontinence, storage emptying, specific complications, and quality of life. It's a good way to actually compare both patients over time and even between different groups. It's invalidated multiple sclerosis, spinal cord injury, spina bifida. This was the questionnaire used in the study that Jeremy published in the neurogenic bladder spinal cord injury quality of life study, comparing different bladder management. To steal from Jeremy's slide deck here, you can see it's a good way to be able to really show with some precision the impact of different bladder management systems within the spinal cord injury population, and just call out kind of the comparison between intermittent catheterization and indwelling catheters. Patients who had performed CIC actually had perceived a lower quality of life in the neurogenic bladder symptom score compared to indwelling catheters. Likely explains why patients like using indwelling catheters so much. There's another study from that same cohort and kind of looked at, for the patients who are dissatisfied with intermittent catheterization, why were they dissatisfied? What were other factors were associated with it? About a quarter of the patients who performed intermittent catheterization were really dissatisfied by it. Strong association with female sex, urinary tract infections again drove dissatisfaction, and poor bowel management also drove dissatisfaction. So looking at this, I would make the argument that quality of life is actually a big driver also to consider a more aggressive therapy like cystectomy and diversion for these patients. If it's a refractory quality of life issue, they may have a safe system, but if it's something that's really driving their quality of life and causing great problems, cystectomy may be a very good option to actually improve things to reach a better state of health and happiness. So very briefly, Sean did a very nice job talking about stomas. For patients with a high compliance bladder, I use this sometimes, Boari catheterizable stoma with a very high compliance bladder, and patients, particularly females, who just can't catheterize their urethra. As an alternative to cystectomy, it's a quick procedure. You don't even have to enter the peritoneum, and you can just use a redundant bladder and put a continence valve in with plication at the base, and it can be effective for some patients. But how I think about cystectomy, as we're moving forward to talking about that a little bit, Bo Schembechler was a coach at the University of Michigan football. And to put this in context, football is almost like a religion at the University of Michigan. And Bo Schembechler is one of the high priests. More than anything, his quote kind of is spoken of very, very frequently in the context of football, is that no person is more important than the team, no coach is more important than the team. And I like to think of this as cystectomy is how we care for these neurogenic bladder patients. This is a team effort, and it's the patient needs to be involved, their care team needs to be involved, the surgeon needs to be involved, the care afterwards. But even to expand this kind of more broadly, we need many minds thinking about this. There's very little validated evidence to show a true pathway in this. And so we need more people excited and thinking about this and kind of publishing the results and engaging in academic discussion. That's why I think these conferences are so important. And I really appreciate the opportunity to talk to the group. So very briefly touching on preoperative care, echoing Jeremy's talk, I actually think that assessment of physical functionality and then the consent and preoperative teaching to understand what the resources is critical in the neurogenic bladder group. Without understanding this, you may be committing them to actually resources that they're not able to use, or the care that they're not able to commit to. So this discussion is critical, and the kind of an assessment beforehand as to the expectations of the neurogenic population is necessary. We've talked a little bit about bowel preps. I rarely use a bowel prep for neurogenic bladder patients when I'm using an ileal conduit. And there's, as to echo again, there's no evidence to suggest a mechanical bowel prep helps improve with an ileal diversion. From a practical standpoint, a bowel prep when using ileal loop causes massive bowel distension, and particularly in the colon for these patients, and it can actually just make physically working difficult. I will echo very strongly, if I'm using colon, absolutely a bowel prep is important. I do think it reduces morbidity. Frailty, underappreciated risk factor. Like the collagen discussion earlier, frailty, particularly in elective surgery neurogenic bladder patients, thinking about somebody like with progressive multiple sclerosis, understanding their frailty score is really going to give you some ideas to the morbidity that could occur after the procedure. So that being said, morbidity in urinary diversion in the neurogenic group is high. 2008, there's a very nice study, 102 patients. They showed that there was a 43% perioperative morbidity and a 35% late complication morbidity. Early morbidity was pyelonephritis, slow bowel recovery. Late was ureteral obstruction. And these high numbers in the 30s and 40s actually are preserved in multiple different groups. It is a morbid operation at least in the first 90 days for these patients, and that's something to have discussions about. MS patients, very similar to spinal cord injury. You can see that there's significant perioperative morbidity and late complications. However, I do think that it's important to look at the outcomes here. One of the things that we looked at is how well does it preserve renal function. We took a look at 46 urinary diversion patients with some extended data and really showed good preservation of renal function. We kind of defined a 25% decline in renal function post-op as a significant change. And only patients with hydronephrosis beforehand, those are the only ones that showed some association with it. Small numbers, and so it's difficult to extrapolate. But I do think that this is an operation that can offer good protection of the upper tracts if that's something that's very concerning for these patients. There's also good survival. We looked at 141 of our patients over time, and this included a large number of the neurogenic population, and we compared whether or not they had complications in the first 90 days versus not, and it did not change long-term expectation of survival when we use the Social Security Death Index in the United States to look at it. So I do think also that this offers good longevity and protection over time for patients. Urinary tract infections, there's good evidence to show that patients with significant UTIs, particularly in MS, benefit from diversions. This was a study that we looked at when I was in Boston earlier. We took 26 patients that treated with ileovesicostomy or an ileal loop and significant improvement in urinary tract infections afterwards. And so I think, again, refractory safety issues, urinary tract infections, protection of the upper tract, urinary diversion can be a very good option for improving the health of these patients. Spina bifida, I think, is almost a little bit of a different situation. There is multiple studies showing that there is a high rate of complications in spina bifida patients, and maybe it's because of the congenital nature of this and the multiple interventions they've had. Many of them have shunts, but very high complication rate. And I think very hard about offering a urinary diversion of spina bifida patients just because of the perioperative and postoperative morbidity. I would make an argument that these patients probably carry a higher risk than spinal cord injuries or multiple sclerosis patients. And there's some NESQIP data from the US to show that even treating stones, these patients have worse outcomes compared to others. So when you're thinking about, touch very briefly here about technical considerations, what do you do with pyocystis? do you leave the bladder behind? For a benign operation, some patients may think you want to leave the bladder behind to be able to shorten the surgery. Pyocystitis can occur in 15 to 50% of patients. I tend to remove the bladder. I think that it reduces the risk of infections over time, unless there's some complicating situations. For benign quality of life issue, if there's significant pelvic inflammation, sometimes we'll leave the bladder behind to avoid it and just manage the infections afterwards. But I try to remove it when I can, and I'll use the supratrigeminal cystectomy that was described earlier. What do you do with the bowel? I think that there's considerable morbidity from neurogenic bowel, and that also drives quality of life, like we touched on earlier, and it can affect how they perceive their urinary system. This is kind of an echo of a study that Sean mentioned earlier, and this was a neurogenic bladder research group combined study, which we looked at whether or not there is increased morbidity for patients who had colostomy either during urinary diversion or after. And what we really showed that there really was no difference in terms of morbidity or recovery length of stay in patients that they had a colostomy at the time of urostomy versus it was staged later. Again, these patients, there's a high degree of high-grade adverse events, but it didn't really alter a lot of the comparisons between the groups. Somewhat small numbers, but I try to offer colostomy at the same time as urinary diversion in patients who have significant bowel complications. Very, very briefly, we'll talk about ileovesicostomy. This was something that Ed McGuire popularized. Essentially, it's a piece of ileum that's sewn to the bladder and brought out as an ostomy, avoids a ureteral dissection and protects the ureteral vesical junction. And earlier in my career, I'd done a lot of these, and we published some initial good results of this. However, I rarely offer this surgery now, and I'd really advise think long and hard before offering it. Over time, we've really come to appreciate this arrow shows a kinking of the ileal limb as the patient gets older and the bowel becomes more redundant. I've had to do multiple revision surgeries on these patients, and maybe it's a good operation for a specific small group of patients, but I would suggest it would likely need a revision or reoperation later. And I think it's better just to do a urinary diversion with an ileal loop instead. And so in conclusion here, I would say that a urinary diversion is a very useful tool for managing these complex neurogenic bladder patients. It can help improve safety issues such as protect your upper tracts, reduce urinary tract infections. But again, I hope that made the case that thinking about quality of life in these patients is also a good decision driver to offer something like this for the patients. Informed decision making, sharing of risk, understanding a little bit more is critically important. But once the patients have a good understanding, I think it's a very good option for these patients. And again, I'd like to thank for the opportunity of talking about this with this group here. And Toto, outstanding conference. I really appreciate it. This has been fun to put together and be part of. So thank you again.
Thank you very much, John. So I would like to call on my co-moderator, Professor Martins. So I think I would like to start with something that's very hot now on the chat box. It's something that Sean mentioned a while ago. Everybody's wondering about the dilute vinegar solution, Sean. How often do you use that?
You know, the evidence for dilute vinegar solution is not very strong, but that doesn't keep me from using it. These patients with recurrent urinary tract infections are pretty desperate for a solution, and they want to go straight to daily oral antibiotic prophylaxis. And I really try to slow that progression down, keep them away from going to daily oral antibiotic prophylaxis. So I'll try anything I can to put that off. And we'll start with bladder irrigation with saline, and then we'll progress to vinegar overnight, and then gentamicin overnight, and then finally to either self-start antibiotics or then finally oral prophylaxis on a daily basis. So to get back to your original question, how often do I use vinegar? I probably prescribe it to a new patient once every few weeks with recurrent UTIs.
Okay, that's something new because we are very, Filipinos love vinegar, so it's very accessible here in the Philippines. So when you mentioned that one, everybody started jumping on the chat box. There's a question here, John, from my text message here. They're asking, when you do need bowel preparation, How do you do that? Because traditionally we do that in a span of 2 days. We start with clear liquids and then non per orum on the day before. How do you do that exactly when you do need a bowel prep?
Yeah, so very good question. I like a Nichols bowel prep, which is using kind of an antibiotic. I use neomycin, erythromycin as an antibiotic base, and then I even though you need to check your renal function beforehand, I like to use Go Lightly as a prep. I usually start it 2 to 3 days beforehand, and then the day before surgery, I usually give enemas until clear. In our system, many of these patients, I will admit 1 to 2 days beforehand actually to complete a bowel prep, because I find the neurogenic patients, they just don't do it at home. It's so impacting on their quality of life, and they sit in stool. So I actually admit these patients when I'm going to be doing a bowel prep at least a couple of days beforehand, and I have them try to get started on things a little bit at home.
And I'd second what Dr. Stoffel is saying there. You know, these neurogenic bladder patients also have neurogenic bowel, and so they're much more constipated than your average patient. And people will reference these articles in the colorectal literature saying you don't have to do a bowel prep, but the external validity of those studies doesn't really apply to our neurogenic population who have chronic constipation.
I actually agree with that one, Sean. And here's a question, a phone-in question for Jeremy. He was just wondering if the non-everted stoma will result in herniation down the road, because it's something new that we just learned about.
Sorry, Toto, can you repeat it?
You mentioned about the non-everted stoma, and an anonymous urologist here was asking, do you think, is there a danger that herniation will occur down the road?
I don't think there's any increased risk of herniation for the non-everted stoma. I don't think there's any data on it, but it wouldn't make sense to me that there'd be increased risk. There's been a few studies that looked at fixing the stoma to the fascia, and I primarily think of that as preventing stomal retraction in the perioperative period. That hasn't been shown to decrease herniation. There's some data emerging about ileostomy and colostomy and placing prophylactic mesh at the time of creation of the stoma. And that hasn't been done with ileal conduit other than in a small retrospective series. So that could decrease herniation risk. I've done that, and I have to say that the worst incarcerated hernia I ever saw was in a patient that had that done, and it created very tight fascia. So as always in surgery, you know, you can shoot yourself in the foot by trying to improve things. So I'm not sure whether I would do that unless there's compelling data that comes out in a large number of patients.
Thank you very much. Another question for you, Jeremy, from Dr. J.U. For Dr. Myers, how do you optimize nutrition of the patient with low albumin before doing urinary diversion surgery?
So usually I'll rely on supplements. You know, I talk to them about a high protein diet and then use an Ensure kind of supplement with high protein, and then follow their nutritional markers. Albumin is relatively, it adjusts relatively slowly over time, other than the perioperative kind of drop that you see immediately after surgery. That's more of an acute marker. So the marker that I use is prealbumin. And so you like to see the prealbumin rise into close normal level before you do the operation. The albumin may lag behind that. So it's mainly supplements. And I find that even if patients are having a hard time with eating and they're kind of catabolic, they don't have appetite, they can usually get down a few supplements a day.
Thank you. Sean, we have a question here from our chairman, from our department chairman, Dr. Bolong. And he is asking about your experience. What percentage of patients opt for ileal conduit versus continent pouches when they are both options?
In my practice, I'd say that when we're doing a cystectomy and we're creating a heterotopic diversion, so the choices between like an Indiana pouch or a conduit, something on the order of like 95% of patients end up with a conduit versus a pouch. And that's usually because they've had radiated bowel. And I feel like the conduit gives me the flexibility to use any segment of bowel from the ileum to the more proximal ileum to the sigmoid or T colon. Whereas if I'm going to make a heterotopic pouch, that's going to be an Indiana pouch, and it locks me into one segment of bowel, which is the cecum and the terminal ileum. So I think it's safer to have the option of the conduit.
I'd agree with Sean, especially if patients have had abdominal radiation, like cervical. You know, their bowel is quite affected by the radiation. And I've kind of learned through the hard way that those patients really should not undergo a Indiana pouch. They're just so prone to devastating complications. If they've had radiation injury, I'll still do a pouch for gynecologic patients that have had radiation and are undergoing pelvic exenteration. And that's a different patient population. Radiation injury patients and having had radiation are different physiologies.
And I'd just add very briefly too, I think when thinking about the neurogenic patients, I have made the mistake of overestimating a patient's hand function. And so as part of when you're screening patients for continent pouches, I actually have them either go to occupational therapy or I'll see if they can put a straw in a Coke can just to make sure that they're able to do it. Many patients will come in thinking that's what they want, but when you actually show them what's needed to do it, they may not actually have the hand function or really the support to be able to do intermittent catheterization through a continent stoma.
Actually, that's something that worth noting, John, because I agree. You sometimes forget about the simple stuff, especially the hand movement. So I agree with that one. That's something that I need to take into consideration also. And Dr. Bolong John here is asking, for neurogenic bladders, what is the difference in the care of spinal injury trauma versus spina bifida as far as care and complications are considered?
I think it's a great question. And, I think a lot of it has to do also with where they're entering kind of care in the health system. Many times, I think the spina bifida patients, they have a strong association of entering into the health system already. And many of the patients have had excellent care and the urologic care has been continuous from the time that they've been from time they've been born. And so the job as the adult urologist is really transitional to kind of keep that care going for patients. And many times for surgical plans have already been developed and there's already a good care plan in place because they've had multiple surgeries. Spinal cord injury patients, I think there's a great need for urologists to be involved earlier in their care, because I think a lot of these horror pictures that you show that I show and everybody see is people who have just not had urologic care, and you end up fixing a huge problem that's preventable. And so, I think it really has to do with kind of the care plans. I'm not sure that there's a huge difference in terms of the goals of management of the bladder for either one of them. It's just really where the urologist, I think, is entering into the care plan, and what's our role? Is it supportive, or are we the fix-it people to try and address a hugely challenging problem that's already been created?
Thank you very much, John. Professor Martins, an anonymous urologist here is asking, do you have patients develop severe complications after a pyelocolon diversion or transverse colon conduit? You're muted, sir.
Oh, sorry. T colon diversion is not very commonly used in my practice. I either use an ileal conduit segment for both cutaneous diversion and orthotopic reconstruction. But in cases that I've used colon, The complication rate is not that different. It's mostly for radiation patients, etc. Most of the complications come from the radiation treatment, not from the diversion. So if that was the question,
yeah, and
I've had
I
a
think
couple patients that have had thrombosis of their conduit in the perioperative period for colon conduit. And both of the patients were quite debilitated and had palliative sort of diversions, and that might have played into it. But I think the larger vessels maybe somehow, and I've speculated maybe that was why they were more prone to thrombosis. Both those patients we kind of had to take back and replace their conduit. That's probably out of 40 or 50 of these conduits. So I think it has to do with probably the patient selection for conduits being a little more complex.
Yeah, I agree with that one, Jeremy. Here's a question for Sean. Among post-RT patients, what are the risk factors that might predispose them to having an increased risk of complication after urinary diversion?
You know, in the two papers that Jeremy and I showed, one in cervical radiation patients and one in prostate radiation patients, it was really hard to tease out what the predictors were, but it seems like nutrition is a strong factor. In one of our papers, a high BMI was actually protective. They developed fewer complications, and a low BMI seemed to put them at higher risk, which is, you know, maybe counterintuitive, but it may have something to do with nutrition or some type of calorie reserve when they get sick post-operatively. There's other things that are hard to measure. When you look at our paper, I'd say that the continent diversions presented more complications. It was just hard to prove statistically. And we've already talked about some of the reasons why, like with a continent diversion, you end up using some radiated bowel.
Yep, I agree. This next question, I will direct this to Professor Martins. In salvage cystectomies and prostatectomies, what's your tip in avoiding the external iliac vessels when you stay near the pelvic bone? There's usually no plane in post-radiated patients. Do you see the question in the chat box, Professor Martins?
Well, actually, there are no very different trips to recommend. It's just like any other type of cystectomy, unless the planes are really frozen, and that's when you have to back out. But most of the times you can get away pretty well with the lateral dissections, and as Dr. Elliott said, and I agree fully, you can keep your dissection as lateral as possible, and you should do that, but avoid the vesicorectal plane. That is where you have to be close to the bladder. Otherwise you're risking fistulation and the dual diversion. Well, I mean, definitely dual diversion. So it doesn't matter if you leave some bladder tissue behind. It's been radiated already, so it should be necrotic, not oncologically viable. So that's my main recommendation.
And I will always look at
there's one thing. Sorry, there's one thing that I'd add to that is that ureters, you should avoid digging those out of pelvic fibrotic tissue. You know, you're never going to be able to use that ureter anyways. And it is so hazardous to take a fibrotic ureter that's plastered into this fibrotic plaque over the vessels. That's just a disaster waiting to happen. And so I often really accent that with the residents is just clip the ureters and take them above where they're viable. You don't need to dig them out of there. You can't really do a ureterolysis in pelvic radiation cases.
I completely agree with that. Yes, I completely agree with that. Most of the ureter division is at the level of the iliac crossing. I don't go further down. I may try to go further down, but even if I can mobilize it, in most cases it's not viable to use those urethral segments for reconstruction. So we'll have to leave them out.
And Sean was presenting a slide a while ago where he ranked the easiest to the most difficult. But in my opinion, they're all difficult, Sean. So there's nothing easy there. So,
No, you're right. It's hard and harder.
I know, right? So I mean, I was looking at your slide a while ago, and you said easy, but in my mind, I was thinking, no, this is not easy. Okay, so Dr. Stoffel, you mentioned earlier the need to regularly check the compliance for patients in chronic indwelling catheterization. How would you recommend we follow up, or how often do we need to check compliance for these patients? Also, is there data comparing quality of life for suprapubic tube versus CIC, or suprapubic tube and indwelling catheter? Thank you.
No, great questions. And this was a question that kind of mobilized a research group, the Neurogenic Bladder Research Group, to study about what is the quality of life differences between different bladder management. And it was very surprising to me, and Jeremy's paper, when it was published 2019, looked at it, the quality of life of indwelling catheters is very high, and patients perceive a very high quality with it, in many cases higher than intermittent catheterization. And it probably explains, when you look at kind of longitudinal studies, of why patients drop out of intermittent catheterization and move to suprapubic tube. It's something that I think the quality of life is easier for many of them times, many to manage. I think that I like to get compliance studies at baseline, particularly for patients, who I feel like are at risk. Indwelling catheters, absolutely, I think is something to be able to look at in the spinal cord injury population. And I think that if it's safe, I tend to follow initially fairly closely with yearly studies, and that if it's stable, kind of look more to see whether or not there's any markers of change, like changes in incontinence, follow their renal function, look at upper tract changes, and bump out the intervals to multiple years. I find that if you just try to aggressively follow compliance and it's normal, multiple studies, they just stop coming back because nobody really likes urodynamics. And so I try to kind of map out a plan for them to be able to say, all right, if we get it stable, we'll be able to follow up a little more liberally. In patients, though, like for progressive diseases, like things like multiple sclerosis or other patients, I actually like a suprapubic tube a lot for them. And kind of looking at what's their longitudinal expectation. If their life expectancy is going to be 2 years, I think we study compliance if it's a factor to reduce urinary tract infections, but tend to just try to use supportive care with the suprapubic tube and emphasize quality of life for them. So I think it has a lot to do with kind of the longitudinal plan for the care based on the natural history of the disease.
Thank you very much, John. I agree with you. When you said that nobody likes urodynamics, I totally agree with you. Okay. There's a question here, Jeremy, from our chairman again, where a colostomy needs to be done for advanced rectal malignancies and urinary diversion is needed. Do you consider doing a ureterocolostomy?
So I've only done that once, and I've always been told that is not a good quality of life and leads to a lot of, severe infections. Any non-refluxing ureteral anastomosis, especially when you have between feces and urine, is very prone to developing stenosis. And that's what I've seen in a few African patients that have come here that have had uretero SIGs for bladder exstrophy in Africa, is that those patients are very prone to developing scarring and needing nephrectomy or reimplants or diversion of some other type. So I wouldn't consider that unless it's last resort. And that's the only situation where I've gotten into it is when I just could not get any viable bowel and the patient had a pre-existing colostomy.
Yeah, Thank you very much for that. A question here, John, from Dr. Bisnar. What's your preference for catheterizable stoma? For Filipinos and children, we usually have a short appendix. Any comments on Monty, Mitrofanov, Bowari flap stoma?
It's a great question, and I think we looked at this in the neurogenic bladder research group also, and had kind of to see whether or not there's different complications associated with it. And Sean and Jeremy, they can speak to this. Use a lot of Indiana augments with using colon and the terminal ileum. After talking with them, I started to do more of those, and it's a bigger operation, but maybe there could potentially be better continence with it. I tend to use a lot of Monty stomas for patients where I tubularize a piece of small bowel and plant it into the bladder. That's what I've always been comfortable with. And when we studied it, there wasn't a huge difference between the two, but probably you get a little bit more better options with an Indiana augment. The Bowari stoma, I'll address that really quickly, is I like that for the patient who just needs to catheterize per urethra and just can't access it. And so it's for somebody who has a very high compliance bladder. And these are patients who routinely are storing 500 to 700 to a liter. And sometimes if you just move the access point for them to be able to catheterize, it makes a world of difference for them. Most patients aren't a good candidate, though, I think, for Bowari stoma.
Thank you very much. Another question for Dr. Stoffel from Dr. Katipay, one of our senior urologists. Dr. Stoffel, how about augmentation cystoplasty in treating difficult neurogenic bladders? Do you give it a relatively high priority?
I like augmentation cystoplasty a lot. I think it's a really good option for the patient who is committed to intermittent catheterization. They have a safety issue with compliance or UTIs or a quality of life issue. And it's I think for the selected patient, I think augmentation cystoplasty with a continent stoma can be a big improvement for many of these patients. And so for the selected patients with good hand function expectations, I will present both urinary diversion and augmentation as possibilities. I think for the patients who have increasing debility, kind of maybe not realistic expectations of catheterization, poor resources, urinary diversion, I think is a superior option just because there's less moving parts and they don't have to manage it as closely.
We looked at, actually in the neurogenic bladder research group, we looked at patients that underwent Botox with CIC, patients who were on CIC, and then we looked at augmentation cystoplasty. And we found that patients with augmentation cystoplasty had significantly improved satisfaction and less symptoms. So I do think it's a very good option for patients that are motivated to stay with CIC, but their bladder symptoms are kind of precluding that and they need to do something else. And usually the patient will tell you they have very strong feelings generally about what they want. Do they want a suprapubic tube? Do they want to stay with CIC? They don't like bags. People are looking at them enough with their using their wheelchair. And they can kind of guide you very quickly about what they're looking for.
Yep.
Doctor, can I make a short? Hi, Doctor. Can I make a short comment?
Yes, sir. Of course, definitely, sir.
Going back to the Mitrofanov and taking John Stoffel's comments. Actually, we've noticed that Mitrofanovs don't work as well in adults as in children. I don't really know why, but we assume the tip of the appendix gets more easily ischemic, and the stricture rate is much higher, and patients cannot catheterize, and we prefer to go with the Monty procedure. Just paraphrasing.
I will echo that. I always am very envious of my pediatric colleagues who have skinny abdominal walls and large appendixes to work with, and I've uncommonly used the appendix now just because it's not possible. I completely agree.
Yeah. Sean, Dr. Mahatma Acharya is asking, do you have any experience doing a Macedo technique? I'm not familiar with that, I have to admit.
Yeah, I'm not that familiar with it either. I had to Google it while you were asking me. And I see it looks like a sort of ileovesicostomy that's catheterizable. Correct me if I'm wrong, but no, I don't have any experience.
Any of you guys have any experience with the Macedo technique? I don't have any experience with that one. Professor Martins, you are the most experienced.
Never heard of it. Sorry.
Okay. Okay. So if there's no more questions here, I would like to ask you guys to stay on first. I'd like to call on our training officer, Dr. Roderick Arcinas, for final words. And we will also show a trailer for tomorrow's day 2. Today's session is actually the happy group. We are the diversion group. Tomorrow's session is the nightmare panel. So we will be doing an M&M. So this is actually the happy group. So I'd like to call on Dr. Roderick Arcinas to give the final remarks. Please unmute Dr. Arcinas.
Hello, good evening. Can you hear me, Toto?
Yes, of course, definitely.
Yeah.
Go ahead.
Good evening to all, and good morning and good afternoon to our speakers. Thank you for accepting our invitation, okay, and sharing your expertise on this topic. I would like to congratulate the organizers, headed by Dr. Mark Joseph Abalahon, or popularly known as Toto, for this fantastic postgraduate course. This is just day 1, by the way. And of course, endless gratitude to our speakers, Dr. Martins, Dr. Elliott, Dr. Myers, and Dr. Stoffel. And we are very sorry for the time difference. Sorry for the sleepless night. Moreover, I believe, yeah.
I was going to say we owe them a cup of coffee.
Yeah, Tato. Moreover, I believe this is just the beginning. We are looking forward to future endeavors with you. And more importantly, this is just the beginning of a great friendship. Okay, so today, we gain not just knowledge, but friends too. Do you agree, Toto?
Yeah, of course, definitely.
Jeremy, John, and Francisco. Not just to our institution, but of course, to the whole Philippine Urological Association. You are very much welcome here. So, Sean, you are very much welcome to go back here in the Philippines. We will take care of you.
There is actually a reason why Professor Martins is dying to come back to the Philippines. So he had this taste of Filipino hospitality. So we will if it's gone by next year, we will try to bring you guys here, and we will show you our brand of hospitality.
Thank you.
So before we end the session, I would like to show.
Looking forward to it.
Yeah, definitely. The teaser video for tomorrow, Dr. Ginto, can you please play the teaser video for tomorrow so the audience can see it?
Before.
There. So again, we are the happy today. Tomorrow is going to be the nightmare. So with that, I would like to thank all our sponsors. I would like also to thank the audience, and we hope to see you all tomorrow. Thank you and good night. For our speakers, can we just have a photo op? To my dear residents and my fellow attendings, can you please turn on your videos so we can have a photo op with our guests? So we have a lot of attendees. I was quite overwhelmed with our attendance tonight. So thank you, everybody. So Paolo, can you please take a picture? These are nine pages of attendees. Paolo, can you please do it? Can you please unmute yourself, Pao, so we can we know if we can stop smiling. Okay. How many? Are we okay, Pao?
Done.
Done. Okay. So again, thank you, everybody. My greatest appreciation to Jeremy, Sean, and John, and of course Professor Martins. And we promise to bring you some day here in the Philippines. And we haven't forgotten about your scrubs, your shirts. They're coming. They're coming. Good thing we ask you about your heights, because you know the average Filipino height is about 5'3", and if we follow that average height, John will have a problem with his scrubs. So, so thank you very much. They're coming. So again, thank you guys, and good night. Thank you, thank you, thank you, everybody.
Good night.
Good night, Kara.
Good night.
Good night. Good night. Good night.
Thank you.
Thank you.
Nice job,
Bye-bye.
Toto.
Thank you. Thank you.
Nice,
Thank
good
you.
job moderating.
Thank you very much.
Excellent. Excellent. Thank you.
Great conference. Thank you.